our first speaker is Richard Packard, MD, who comes to us from London, England, where he maintains his own medical practice and serves at the University of London. He's an international speaker, author, and recognized expert in cataract surgery. And by way of a recorded presentation, he's going to speak to us about the importance of IOL capsulotomy positioning and relative to the visual axis in his talk titled Visual Axis Centration of Capsulotomy and IOL Using Automated Capsulotomy Devices. Go ahead and start the video.
I'd like to thank Deborah Osborne very much for inviting me to be part of your meeting. I'm going to be talking to you today about visual axis centration of capsulotomy and IOL using automated capsulotomy devices. My financials are here at the bottom of the screen, and the only one that is relevant is Exolens. I'm a consultant to a company that makes one of the lasers that I talk about in this talk. So let's think about the capsulotomy first of all. Capsulotomy started out as a crude tearing of the anterior capsule, and we see this with Daviel in the 1750s, with Hal Ridley with his Hess forceps in the 1950s, with Charlie Kelman with the Christmas tree, and then we move on to the 1980s with the can opener capsulotomy and Dick Kratz. And then in the mid-1980s, we had a new approach. This was the continuous curvilinear Capsulorexis. Howard Gimbel gave us continuous, Kimi Shimizu called it curvilinear, and Thomas Neuhan called it Capsulorexis. But the object of what they were trying to achieve was a smooth edge, and you can see there different methods of trying to achieve this, each of them using a cystotome. But where they were first to perform this, Calvin Ferko from North Dakota began using a continuous tear circular capsulotomy in 1978, but he didn't present this at a meeting until 1986. A number of ophthalmologists have written confirming seeing this surgery performed by him in the early 1980s. And here we can see him doing the surgery now, using the Stort's irrigating cystotome, using a technique quite similar to what we saw from Howard Gimbel. So it may be that he should be given credit for being the first to do this, even if he didn't popularize the technique as the others we've seen before have done. Although many still use a needle for Capsulorexis, Peter Utrata designed special forceps for the capsulotomy in 1988. We can see them here. And this made the capsulotomy much more controllable for many surgeons. But what were the consequences of this new capsulotomy? Well, it meant that the IOL should and could be placed reliably and securely in the capsular bag. Previous phaco techniques requiring the nucleus to be tilted would become much more difficult. And therefore we needed new phaco techniques, and these were developed to overcome these difficulties. So there was chip and flip, divide and conquer, nuclear fractus, phaco chop, and pre-chop. But what about the centration of the IOL in all of this? And we can see this in this study from Pablo Perez Marino and Susana Marcos. It was a custom model eye that they used, and they did this with three aspheric type lenses, the Hoya Vivinex, the Avitok Technis, and the Alcon IQ. And you can see the further degree of decentration that you get, both with the Strel ratio and also with chromatic aberration, the greater decrease you get in the quality of vision. But could the CCC be made more precise to improve its centration? Here we can see the Tassignon ring, which Marie-Josée Tassignon has invented, and this is placed on the surface of the capsule, which is centered on the pupillary margin. The problem with this is that although we have it centered on the pupil, it's not centered on the center of the visual axis. We can see something similar here with the Verus capsulotomy ring. This is again placed on the anterior capsule. It's centered on the pupil, but as you'll see, once the capsulotomy is created, it's centered on the pupil but not on the visual axis, which is provided by the first Purkinje image, and we'll talk more about that in a moment. Here we are. We've now removed this from the eye, and that's where the capsulotomy is. You can see that it doesn't bear too much relation to the visual axis. There's the first Purkinje image. We use a corneal marker. Again, this is being used and centered on the pupil rather than the first Purkinje image. And you can see there that the Purkinje image is not centered where you would want it to be. You can also use the heads-up overlay on the microscope that you get with Varian. Again, the surgeon here is using the center of the pupil rather than the visual axis. And although it's useful to help with the sizing of the capsulotomy, it's not useful for centration unless you use different landmarks. And we can see this again here. The centration is not on the Purkinje image, it's on the pupil. However, there was still the issue with the CCC that you needed a good reflex to be reliable. I'm sure all of us remember the days before we had any other means of doing the capsulotomy in these white eyes, which made life very difficult. First thing that came along to try and help us was the Clotey high-frequency radiodiathermy, and in fact this has been recently revived by Oertli for doing the capsulotomy. The problem was that this created a ragged edge which wasn't nearly as strong as a manual CCC. But the use of a simple vital stain, trypan blue, solved this, and this was first publicized by Garrett Mellis in 1999, but in fact it was Minas Coroneo working in the outback in Australia who first used this dye to create the capsulotomy in some of the very advanced cataracts that he saw there. In fact, he holds the patent on the use of this particular dye for capsulotomy. And we shall see the importance of this type of staining soon in another approach. So why might we be concerned about the size and centration of the capsulotomy anyway? If it's not round, it can lead to asymmetric contraction and IOL decentration, as we can see here. On the left, there's early fibrosis at 1 month postoperatively in this eye with a silicone lens. Here we can see a more advanced asymmetric fibrosis and the lens is starting to decenter, and you can see this more acutely in the image on the right. If it's too small, then it will create difficulty with your surgery, and also there's the later risk of anterior capsular shrinkage. You can see on the left how much this capsule has contracted. On the right, even more so, so that we've got a really small opening in the pupil with this capsular phimosis. And these both have been reported in the literature, both from Jim Gills and also from a group in Korea. Shrink wrapping of the IOL by the capsule to lessen PCO and the overlapping IOL edge will also avoid lens tilt. This is from a study using very high resolution cameras from David Spalton and his team. A couple of studies here, and what they showed was that if the capsulotomy is not on the edge of the IOL, and this image on the left is at 1 year, PCO is already starting to come under the edge of this Acrosoft lens. On the other hand, on the right, you've got 3 years out from surgery with a capsulotomy that has got 360-degree coverage of the IOL, and it's a completely different story. Iol cell centration on the visual axis and stability are particularly important for multifocal and toric IOLs. Here we can see on the right, first and third Purkinje images in good position in multifocal and toric IOLs. We can see this again here, where the image is not where you'd like it to be, and although there is coverage, it's decentered as far as the capsulotomy is concerned. If you look at a study from Naj and his group, they demonstrated in 2011 that the femtosecond laser was likely to be more accurate because of the sizing, providing that you got 360-degree coverage. But it's also important if you're going to have a capsulotomy fixed IOL. On the left you can see the femtos IOL, which is used with flanges to be held in the perfectly sized anterior capsulotomy, and it's really important to make this work that you get the visual axis. This is also true with the bag in the lens from Marie-Josée Tassignon that you can see here on the left. The capsulotomy centration is not obvious. If you look at this image here, you can see that there are a number of different axes. We've got the pupillary axis, which we've just been discussing. We've got the visual axis that goes through to the fovea, and then the optical axis. And this gives us angle gamma, alpha, and angle kappa. But which one of these is the critical one for best visual function? Capsulotomy centration is a non-trivial issue due to the fact that the eye is asymmetric in 3D. There also can be intraoperative patient tilt, which is particularly important with the femtosecond laser. And if you have asymmetric mydriasis, as is often the case, then this will result in the resting location of the IOL not being where you want it to be. Also, this has been shown in studies that there can be movement backwards and forwards from different sizes of the anterior capsulotomy. And this is further exacerbated in a hyperopic patient where there may be a large angle kappa. And you can see on the graphic over here where the visual axis may be in relation to the pupil center and the capsulotomy and IOL position. If you look at the mesopic pupil and center it to the visual axis, the average displacement is actually slightly nasal at 0.3 millimeters, slightly inferior at 0.1 millimeters, and in the worst case scenario, you can actually get as much as a 0.6 millimeter displacement in hyperopic eyes. And this is important because of the you want to have, particularly with a biaspheric IOL, minimal decentration, because once you get beyond about 0.3 millimeters, the effect of the asphericity disappears. Some small decentration between 0.07 and 0.21 is normal, as we've seen. Anything greater than 0.4 millimeters does cause significant retinal image degradation, and it's particularly true with aspheric and multifocal and toric lenses. This was shown in Sauer's study in 2015. The effect of IOL displacement on visual function is more pronounced as in the study that Ashina et al. Did, where they found this was particularly true in aberration correcting IOLs when compared to spherical and non-standard aberration correcting IOLs, and also in multifocal versus monofocal lenses. However, in a study which is about to be published in the Journal of Cataract Surgery, where they used a finite element model, they felt that although there was, in their conclusion, an anterior capsular regularity or eccentricity with IOL tilt and decentration and rotation and vaulting in a numerically significant number of eyes, they felt that this was optically negligible, which I found rather surprising when they qualified this remark by saying that the stress, which is much greater at capsular bag equator compared with the rexis edge, and very asymmetrically disturbed in all cases, they felt that the biological process would, where big bag shrinkage would actually could produce some decentration. So they were only looking at it, in fact, at the very point at which the lens was implanted during initial surgery. As I've said, if you use the Purkinje images, this is a study from Vance Thompson, Jack Holliday, and David Stretovan, they could use these Purkinje images as a special relationship that would give them a surrogate sign of patient fixation to assist in capsulotomy centration during cataract surgery. Here we can see an example we've seen already of pupil centration not on the visual axis, and this has resulted in 360-degree coverage but not centration for the IOL where you'd like it to be. So if the limbus and the pupil are not the best landmarks, what is likely to yield better centration? We've seen also from Zoltanaj's studies that the femtosecond laser would change the way that capsulotomies would be perceived, because for the first time we could make capsulotomies of a given size, which were truly circular, in a given position, and with little risk of tear out during the capsulotomy, and without the variables of the manual technique. But there were caveats. A second room might be needed for the laser, which would interfere with surgical flow. The cost of the device was high, as was the running costs. And we've seen from a number of studies that the advantages really needed to be shown. Here we can see the femtosecond laser in action. Capsulotomy is being created. There's the laser emission. This then moves on to the treatment of the nucleus, and ultimately the incisions can be done. Looks amazing, but as I've said, the machines cost significantly in terms of capital and running costs. Naj, in one of his original studies, showed that the circularity was certainly better than the manual capsulotomy. But what about centration with flax? We haven't really looked at that. Here's a study which compared prospective apex-centered versus standard pupil-centered femtosecond laser capsulotomy and cataract surgery. Their conclusion was that the centration on the lens apex didn't influence the amount of IOL tilt, but it was important as far as stability of the orientation of the lens. They haven't, in fact, investigated to see how this might pan out as time goes by, but as we've seen already, if the capsulotomy is not on the well-centered, as far as the IOL is concerned, you can get decentration as the capsulotomy contracts and the capsule around it. Here's a study using OCT tomography with three-dimensional confocal structured imaging and with a system-guided femtosecond laser capsulotomy versus manual continuous CCC. And they showed that both of the approaches using the femtosecond laser were better for predictability of size of capsulotomy and also for centration in the immediate post-surgery group, and you expect that over time this again would be better for the better centered laser capsulotomies. I've mentioned about the use of trypan blue. Here we can see a coaxial Purkinje image with trypan blue capsular landmark. We know that the Purkinje images, as I've said, are well accepted for corneal refractive surgery and the visual axis, but what about for IOL centration? If you have this trypan blue centrally placed located anterior capsule staining, is this going to be useful? It's been found in a high proportion of eyes, over 95%. And the diameter of this feature varies between 2 and 4 millimeters. What is interesting is that this landmark was actually noted in studies whereby the capsular cap from femtosecond laser surgery was first of all stained to make it easier to see in white cataracts, which then removed. And you can see it very clearly here just using standard trypan blue. What was interesting that although this feature was reported, nobody discussed it or thought there was any significance to it whatsoever. So here's another approach using a laser that takes advantage of the trypan blue capsular landmark. David Mordaunt is the designer of the laser. He was also the designer of the laser that Johnson & Johnson have. And the advantage of the capsule laser is that it has a much lower capital cost than femto. There's also a much lower cost per case than both femto and PPC using Zepto. There's no disruption in the surgical flow. It uses minimal space in the operating theatre, and it produces consistent accuracy, sizing, and circularity, as well as centration. So how does this laser work? It operates through the absorption of the orange wavelength, 590 nanometers laser energy, onto a trypan blue stained capsule, which then converts type 4 collagen to amorphous collagen. The triple helix of collagen undergoes thermal unwinding due to disruption of the hydrogen bonds, which allows shrinkage. And we can see that here. Above, we've got the type 4 collagen, below the amorphous collagen. How does it work further? Well, as the collagen undergoes this phase change, it creates the capsulotomy with a rim that has a high degree of elasticity and tear strength associated with amorphous collagen. Here we can see SEMs of the disc edge. On the left, you can see that the edge is rolled over. On the right, you can see a cross-section which highlights where the amorphous collagen is. How does it work again in real life? The laser is continuous but not pulsed like femto. We're going to see some surgery from Pavel Stodolka, who's done much of the work on this. It's a scanned laser. It works in a single circular pattern to create the single curvilinear capsulotomy, and it does this in under 0.3 seconds. You can see now we've got the laser focused with the two dots on the right. It's been focused so that the laser can be fired, and once it fires, the capsulotomy is created, and can see how well centered it is. We did a study looking at the strength of the capsulotomy edge, comparing paired cadaver eyes, which were treated with flax, CCC, and capsule laser, and these were each individually compared. So flax was compared to CCC, flax was compared to capsule laser, and CCC was compared to capsule laser. And what we found was that if you looked at the relative tear strength and took CCC as 100%, flax was 70%, and capsule laser was 150%. And this has been reported in the BJO. We looked at another study comparing two matched groups of eyes. 125 patients were involved, 63 eyes treated with capsule laser, 62 with CCC. The primary endpoint was capsulotomy precision, and this was statistically better for sizing accuracy, circularity, and centration precision. We looked at a secondary endpoint of safety, and there were no adverse events for either way of creating the capsulotomy. And we also observed that the capsule laser capsulotomies were 100% free floating with 360-degree IOL coverage. We did a meta-analysis comparing some of the available literature for femto and manual with capsule laser. You can see that the capsule laser appeared to be much more favorable than either of the other modalities. A clinical study has just been completed looking at the intraoperative capsular landmark identification and the use with coaxial Purkinje images. The first 100 eyes, the group 1 had the capsulotomy centered on the mydriatic induced pupil. The second 100 eyes were capsulotomies centered on the landmark. Of the 200 eyes, over 94% had the landmark correlated and with coincidence with the Purkinje image, with displacement of less than 0.1 millimeters. Likewise, the coaxial Purkinje image and IOL centration were also coincident within 0.1 of a millimeter. Mydriatic pupil-centered capsulotomies were notably decentered from the IOL by 0.3 millimeters, whereas the trypan blue-centered capsulotomies maintained their superior correlation with the IOLs with a displacement of 0.1 millimeters, and all reported distance confidence intervals were less than 0.1 millimeters with a p-value of 0.05. The benefits of the TBC landmark being located on the anterior capsule include the lack of sensitivity to tilt, confirmation of patient fixation, and serving as an alternate landmark to the Purkinje images. Here we can see the correlation with the Purkinje image, which is also the same as the visual axis. There are 6 examples here. If you look at the control arm centered on the pupil, you can see what the displacement is between 0.1 and up to 0.5 millimeters. And there's an example of this on the right. We look at the Purkinje image to IOL position with the TBCL centration, you can see that this is much more accurate. We had some further thoughts about this study, because not only was the capsulotomy centration on the Purkinje image superior to pupil centration, but also it was interesting that the resultant IOL position appears to be centered on the visual axis, which implies that the capsulotomy bag is centered on the visual, not the optical axis. And the TBC landmark is associated with the anatomy of the capsular bag. Here hence both are centered on the visual axis. Are there other advanced devices which can assist the surgeon to create the capsulotomy? We've mentioned also already precision pulse capsulotomy with Zepto. This now has a new handpiece with a new nitinol ring, which delivers more consistent energy for strong and precise capsulotomies. The modified suction cap allows improved proximal suction for more consistent circular and centered capsulotomies. And there's an easier to use handpiece with a more ergonomic design for smoother usability. And here we can see the new power console, which has an LED display for improved user experience. And the device cups capsulotomy of 5.2 millimeters. Vance Thompson is seen operating here with the new device. Rapid pulse multipulse energy is what causes the phase transition in the water molecules, and this creates the cut in the capsule. So first the suction device and the incision finder are placed on the capsule, and you can use the Purkinje images here seen to help center it. You allow the tip to become recircularized, keep the push rod in the neck to allow for a certain amount of centration. Here we can see the centration going on. If you keep it in the neck, it allows you to keep it positioned more easily. Suction will then be applied once you're happy that you've got it centered and the capsulotomy created. You push back the BSS and then you can remove the capsule. This is one of the first studies which Kevin Walsh and Vance Thompson did with the device, which gave them hope that this would be very useful in the future. This is what an SEM of the capsulotomy cap looks like. It's actually quite similar to what you see with the Capsulaser. We've already talked about using the images to get centration, and this is the way that Vance Thompson describes his streamlined approach for anchoring cataract surgery intraocular lens centration on the patient's visual axis. However, this device is not completely foolproof. There have been a number of studies done by Brendan Vogt in his group where they found that they've had tear out from what appeared to be perfect capsulotomies using the device. But in summary, let's see where we've got to with this. Using the dilated pupil for centration leads to capsulotomy and IOL decentration. Decentered IOLs lead to degradation of visual quality, and this is greater in aspheric and multifocal optics. There is reduced IOL tilt with improved stability with a well-centered capsulotomy. And there's also an improved 360-degree coverage, which means that there is reduced risk of early PCO. The Purkinje images assist in placing capsulotomy on the visual axis with PPC, as we've seen. And the trypan blue capsular landmark, which is consistent with the first and third package images, is a method for centration of independent for patient fixation when you were used with the capsule laser using the selective laser capsulotomy approach. Thank you very much for your attention. I'm sorry I can't be with you to answer questions. Unfortunately, I will be in hospital having some surgery, and hopefully that'll go well. If you do have any interesting questions, I'm sure there will be one or two, please send them through to Deborah Osborne, and I'd be happy to respond to them by email. Thanks very much.
All right. So if you all look at your screen, there's the CSEPT website address. If you look on the right side, you'll see you click on the meeting. It'll take you to the evaluation form for it. Fill in your name, your email address, and you'll get credit, and we'll get your CME certificate out to you. So make sure you go to the website, fill out the evaluation forms to get your credit. We're going to return back to the CME portion of the program. We're fortunate that with the change in schedule, that we're going to get more access to Dr. Koch, who has agreed to share his thoughts on multifocal intraocular lenses. Dr. Koch is a professor of ophthalmology at Baylor College of Medicine in Houston, Texas. He's easily recognized as an expert as he pursues his roles in research, teaching, leadership, publishing, and lecturing. I'd like to welcome Dr. Koch and thank you for giving us more of your time and expertise. We look forward to hearing this next talk.
Thanks very much, Dr. Lim. Can everybody hear me okay?
Yes.
Great. I'm going to share my screen. I was able to pull up something here that we can talk about. Let's see, let's do this. And what I thought I would be something that's I didn't see kind of discussed on the program was something about multifocal IOLs or addressing presbyopia. So let me share some thoughts about that. Financial disclosures for this talk would be Alcon, Bausch & Lomb, Zeiss, and Johnson & Johnson Vision. So, oh, gee, my screen is not, there we go. Why do we even try multifocal IOLs? Well, we do it because patients come in asking for it. They can provide true spectacle independence, and they retain full stereopsis. A nice paper by Dan Dury looked at the effect of monovision on stereopsis, and with a 3/4 of a diopter of monovision, you lose a little bit of stereopsis from the pre-vision. These were with contact lenses that he tested these patients. With a 1.5 diopter, you lose about half your stereopsis, and you lose a ton of stereopsis if you're more than that. So there is a trade-off with a monovision approach. As much as I like it, and I will say right off the bat, I do a lot of monovision, particularly in patients who've been demonstrated to be very happy with them. But the other issue is, why do we try multifocal IOLs? Well, because they prevent falls by eliminating bifocals, spectacles. One study that Dan Chang has looked at attributed roughly 1/3 of falls to bifocals. And you can imagine the impact that this has on in terms of a public health issue. Well, as clinicians, we know we're really overwhelmed with choices. Now, in Europe, they have this lens. First of all, let me just talk about the methods to achieve multifocality. In Europe, they have this lens, which has distinct refractive zones, the oculentus. I don't know if we'll ever see that in the US. And actually, this one called the Comfort with a 1.5 diopter ad is very popular because it has little glare and it's great for the computer. We're obviously familiar and use a lot of diffractive optics. There are low-ad multifocals, like the Restore 2.5, the active focus, which has now fallen by the wayside because of the EDOFs. And then we have the multifocals that we had used traditionally, which are really, truly kind of a bifocal. And now we have trifocals and we have extended depth of focus lenses in diffractive optics. And in diffractive optics, the step height determines the percentage of light to each focal point, and the spacing determines the add power. And for those of you who have implanted the Symphony, and remember that first time you put a Symphony in the eye, you went, oh my God, these diffractive ridges or steps are so high and they're so widely spaced. Well, that's because a lot of the light was directed to intermediate, and because the greater distance contributed to the add being for the intermediate rather than for the near. There's a technology being used by the VSY lens, the Acriva Trinova, stepless diffractive zones. No experience with it, haven't heard of colleagues in Europe talking about it that much. One of the unique features of diffractive optics is the reduction of chromatic aberration. As we know, the cornea and the lens of the crystalline lens of the eye have chromatic aberration, in which blue light is focused to a shorter distance than red light. Interestingly enough, diffractive optics have the opposite chromatic aberration, where the red light is focused more strongly. And if you combine them appropriately, you can actually reduce the net chromatic aberration of the eye and improve the quality of vision. And this is, again, something that might be relevant if we're thinking about patients who might develop other eye diseases as they get older. It might be a safer option for them. So then this brings us to the new kid on the block in terms of a way to achieve multifocality is what's called phase shift optics, or which Alcon in the Vivity lens is called X-wave technology, which of course is a nice marketing term, but it's something we can grab onto as a name. And then there's and I'll come back to the Vivity, a very important lens to talk about. Then there are the lenses that this is the Mini-Well. It's from Italy. It uses variations in spherical aberration, positive, negative, then positive, to get an extended depth of focus effect. Again, I doubt that we'll see that in the United States. It's hard to know. So what about this X-wave technology of the Vivity? It's an intriguing lens. It has these very subtle little curvature changes on the front that take the wavefront and extend it, and then push it forward so that it actually focuses for the near. This is an interesting slide. Now, comes from Alcon. I'll be showing slides from J&J. I want to just say where they come from, but this looks at light intensity distribution. It's simulated. Here's the Acrosoft IQ. That's their, obviously their monofocal. Here's the Symphony. Here is the Vivity. Now here's the Symphony. You can see that it has a good peak at distance, and then it has an intermediate peak. Both of these are very strong. And here is the Vivity. And what you notice is there's a fairly continuous range in the Vivity from distance right through the -1.5 intermediate. You'll also notice that it's not as intense at distance as is the Symphony. And that will come up again in my discussion. And here's the Panoptix. Distance, a little gap, but then it picks up at -1.75, -1.5, and then goes up to near, which is why, it gives you a nice continuous range in the sort of closer intermediate and near range. So in the US clinical trial, the Vivity showed the monofocal distance vision was roughly the same as in the monofocal IOL. There was good intermediate vision. Binocular mean uncorrected intermediate visual acuity was greater than 20/25. And then the mean uncorrected distance vision was 20/32. Now, distance corrected was a little bit less, as you might imagine, because there's some myopia that probably plays into this being 20/32. But there is, in general, a useful range. They do get good intermediate. I tell them absolutely you'll need reading glasses. Count on it. If they don't, it's an unexpected surprise. And then this is really where the Vivity shines, and that is in terms of glare. And these are halo measurements, optical bench. It's important to recognize this is a 4.5 millimeter pupil, so it will vary according to pupil size. Here's the Acrosoft monofocal Vivity, a little bit more maybe, and then the Symphony, which of course, as we know, has more halos or spoke-like glare compared to a monofocal. So the glare profile approaches a monofocal. I have a couple of Vivity patients with some glare, but very well tolerated. So we've got the Symphony as an EDOF. I like the material of the Symphony a lot more than I like the Acrosoft material. But we are going to get a new material for the Alcon soon with the Clarion. I think it gives a little bit greater range of vision. I get a little more near vision. It has higher modulation transfer function. And I like this lens for post-LASIK eyes. I'm very now circumspect about using the Vivity in patients who have some kind of other cause of visual loss, because there is some low contrast vision loss with the Vivity that I think that can be a concern. But my goodness, the risk of halos is just about zero, so it's very forgiving. And I think with the Clarion platform, we'll have a lens, you know, it'll be a really nice long lens that's going to perform beautifully for the long haul. Well, what about patients with early macular degeneration? I'm just not implanting these lenses in those patients. Maybe a symphony if there are a few mild drusen, but I'm very cautious. Post LASIK, as I mentioned, if it's not too irregular, I'll go with a symphony if the patient wants that extended range. Again, glaucoma with nerve fiber layer loss, maybe a symphony, but not if they have field loss. You know, I'm just very cautious in these patients. And that really brings in another lens, which is the Eyhance, which is an interesting lens because it has a little bit of increased curvature in the center of the lens. And what it ends up doing is giving essentially the same distance acuity as a monofocal IOL, but it gives about one line better near vision, both seen on the bench in all the clinical studies. So here is the Eyhance here, and this is at, you know, here we go, minus 1.5. You can see that it's 0.1 log difference. That's one line of better near vision. Interesting. And I do have some patients with the Eyhance who are, particularly if they're -1/2 or -3/4, they can see their phone very easily. So it is an interesting lens. But again, I don't promise greater near vision. If they get it, I ask them about it afterwards, but I'm very cautious about under-promising and trying to over-deliver. Which brings us to our friends, the trifocals. Of course, we have the Panoptix in the US, and we have the Synergy in the US. This lens, I think the fine vision is in clinical trials in the US, so we may see that. The Panoptix is a really interesting lens. Here's the Alcon Restore, and here's the Panoptix. You can see the tighter ring spacing. There are a lot more rings in the Panoptix. There are 15 as opposed to the Restore 2.5 that had 7 and the 3-diopter Restore that had 9. And it extends out to 4.5 millimeter zone. And the other thing about the Panoptix, it is not apodized, which means that the ring heights are the same from the center to the periphery, so that as the pupil enlarges, the effect of the trifocal doesn't fade. And what they did is they took this is what a standard trifocal looks like with distance, intermediate, and near. And what Panoptix has, it's actually quadrifocal with 4 points, but somehow or other, and then the reason in a trifocal you get the near is it's because it's the second order optics from the diffractive rings. So they target the diffractive rings for intermediate, and the second order optics from the diffractive give you the near. So here's first, second, and third order optics with the Panoptix, and somehow or other they figured about how to take the first order and put it to distance so that the Panoptix is about a 50% distance, 25% intermediate, 25% near. And interesting to look at, here's optical bench performance, again from Alcon, 4.5, which is exactly the diameter of the Panoptix ring, so you have to take that into account. Here's distance. You can see pretty darn good with the Restore and with the Panoptix. There's this intermediate that you're getting, particularly at 60 centimeters. And then at near, you can actually see a little bit better near with the Restore than the Panoptix, but that's because the Panoptix has some of the light focused for intermediate, and there's a trade-off. If you're going to take light away from the near and put it intermediate, the near isn't going to be quite as crisp. And I do have a couple of Panoptix patients who complain of halos at near, even though they can read the letters, and it's amazing how they somehow can't adapt to it. Okay, so the other one is the Tecna Synergy. So the Synergy is an interesting lens. Well, let me go back here. Sorry, I thought I was being chatted at. Let's go back. Okay, so here's the synergy. And okay, big caveat, this is a Johnson & Johnson slide, folks. So just so you know, comparing two different FDA studies, not a one-on-one comparison, but you can see with the synergy there, they claim that there's a little better sharpness at distance and continuously throughout a little bit better quality of vision, even up to getting some reasonable near vision up to about -3 to 3.5. And indeed, these patients do have good near vision. So let's see here if we can. You know, the other thing that's happened is that they've put in a violet filter in these lenses. And the issue is really because of the fact that in our world, we are switching to the different kind of lighting than we've had traditionally. And that lighting is an LEDs, which has a much higher percentage of shorter violet wavelengths in them. And that violet is shown to create a lot of scatter in the eye. It's not well focused in the eye. So this is the market share of LED lighting 2020 compared to 2010. It's remarkable, 65% as opposed to less than 5%, and what is projected to be in the future. So we're going to have a lot of this white light with a lot of violet in it. And so the thought is that by filtering that, you might help patients with their quality of vision. So the other thing they've done with the synergy is they polished the echolets or the ridges to get it smoother. They used the ridges to, again, reduce chromatic aberration, and they have the violet light filter. So comparing these two lenses, you know, it's hard to know whether you have less glare with the Panoptix because it doesn't go all the way out to the edge. I'm not sure that that's really the case. The synergy allegedly has better outcomes in non-comparative data analyses and bench studies. And in my practice, I use the synergy when patients really want that near vision. One of the things about the synergy, though, if I can go back, is look how steep the peak is at distance. If you're off by a half diopter, there's a drop in vision. True for the Panoptix, but I think it's a little more forgiving, although this graph doesn't show it. So you really have to hit your target if your patients are going to get the distance vision they want. And that's a challenge. So I am kind of, if I'm using either of these lenses, I'm starting with a non-dominant eye, putting it in, assessing their glare, their near vision, what they need, and then adjusting for the second eye. And you got to be prepared, as you all know, to see this. And an oncoming car, streets at night, the circle of light covers, the patient has to point out to me where the tires are, the headlights. I mean, you gotta chuckle at this. And here's another one, left eye, diagonal line, 4 rings. This was like 2 weeks in a row. And, you know, I have symphony patients with 0 halos and glare, and I have those that come in really noticing it. But here's somebody for the Panoptix. Lines of light are more intense, halos, lines radiating. So, you know, you got to be prepared. And I tell all these patients, you're going to see halos and glare at night, and you have to, you know, you have to be prepared to accept that. This is an interesting study from Gerhard Auffart in Heidelberg, Germany, where he used an optical bench, and these are different IOLs. And this is a trifocal. This is the Zeiss trifocal compared to the Panoptix down here. You can see a very different pattern of halos and glare. See the spokes that my patients talked about? Interesting. But over here is the Symphony. So here's the Panoptix, here's the Symphony. Maybe a bit more intense with the Symphony, very similar though. Here's that lens from Italy, the Mini Well. You can see it's a smaller pattern of glare with the positive and negative spherical aberration. And here's that lens that I mentioned, that the Lentis, this is a 3 diopter Lentis. No, this is the 1.5 diopter. You can see that there's a little bit smaller glare pattern with it. Interesting. So I'm going to ask you all to pay a little attention to something. This is a paper that was published by Webster and colleagues in Neuroscience in 2002. I'm going to show you 3 images. And I want you to just follow what I suggest. And in these 3 pairs of images, the first and the third pair of images are the same. But I want you to see, this is a little bit of a lesson in neuroadaptation. So I want you to stare at the green dot, look right there at the green dot. We're going to do it for about 10 seconds or so. Stare right at it. Okay, I'm going to change the slide. Keep staring at the green dot. I know you're going to flick on either side and see a hyper sharp image on the left, right, in the cloud, hazy, poor contrast on the right, on the left. But keep looking right at the green dot. I'm going to change it back to the same images we saw before. I hope you all got that, could see that very clearly. It's actually better to do it on a Zoom with patients, with folks at the computer here, because I get it better than I do in projecting it in a room. So the question is, does this always work in our patient? Of course, the answer is no. Now we have some new kids on the block here, small aperture optics. The AcuFocus IC8 is hopefully going to get FDA approval sometime early this year. And it's going to be, I think, a very interesting lens, first of all, for reducing aberrations in highly aberrated eyes, but also in providing increased depth of focus, because you can get some pretty reasonable reading vision with this lens without really any compromise at distance. There was a lens available from Aperture, the extra focus lens, which is a sulcus lens that was available outside the US, but I understand that Aperture is no longer making that. So that's our one sort of small aperture optics option is the AcuFocus IC8. And you can see some various cases that were used for various ways to keratoconus, post-RK, post-LASIK, post-PK, some really good uses for this lens. I'm really going to be excited to get this. And I think that we're going to be doing more of this using the RX site. It's a very precise lens. We have that now. It is certainly not for everybody. It's expensive and it's very labor intensive. And my technicians are saying to me, Dr. Koch, when are we going to do these treatments? Because you're talking about treating folks, 4 times post-operatively at a minimum, maybe 5. And that's 5 post-op visits as opposed to 1. So you have to take that into account. In some practices, the optometrists are doing the treatments, but it is very precise, and I'm really starting to enjoy it from my post-RK patients, for example. And then there are this technology, perfect lens and Claria with refractive index shaping that's still early. But we'll see whether these will really pan out in terms of an ability to take any IOL on any patient and induce multifocality or reduce it or alter the refractive power or toricity. It's very exciting technology, but it certainly has a ways to go. So I'll stop there and be happy to answer questions or take any comments.
We're so fortunate to have more time with you, Dr. Koch. Thank you so much for your extra presentation. There is one question, since you were kind enough to give us more time. Let's see. Do you consider Vivity for any patients for whom you would not consider a Panoptix?
Yes, certainly. If I have a patient who wants extended depth of focus, who has good optics of the eye and is very glare averse or frightened, I think the Vivity is a great choice. I think it's a really nice option for them. They get that extended range of focus, but I do find that the Vivity patients are more affected if they get a dry eye post-op. They're more affected with the capsular pacification. So there is this sort of still multifocal compromise that comes with that lens. But definitely that's the case.
Thank you. If you wouldn't mind, Dr. Koch, going on to the chat and answering some of the other questions that are up there, you generated quite a bit of interest. So thank you, and we look forward to your 11 a.m. presentation. Our next speaker is Jean Ramsey, and we've asked Connecticut's Steve Thornquist, MD, to introduce her. But I'd like to first mention that Dr. Ramsey is also a friend and colleague of the Connecticut Society of Eye Physician Leadership and Legislative Liaisons. And I would like to thank her for all of her support and guidance in protecting patient safety, both regionally and nationally. And with that, I'll turn this over to Dr. Thornquist to make the introduction of our friend Jean Ramsey. Steve?
Thank you, Ed. Can you hear me?
Yes.
Okay. I'm really honored to be able to introduce Dr. Ramsey. She's an emerita professor of ophthalmology and pediatrics at Boston University School of Medicine And she's worked as a pediatric ophthalmologist at Tufts, Mass Eye and Ear, Boston University, where she was also vice chair of education and the residency program director and associate dean at the Boston University School of Medicine. She's been very active in both legislative and regulatory arenas for the last 25 years and has championed a bill for pediatric vision screening in Massachusetts. She was council chair at the Academy of Ophthalmology and served as on the Academy's board of trustees as well. She's also been held several officerships in the American Association for Pediatric Ophthalmology and Strabismus, and she currently serves in the leadership position at the National Center for Children's Vision and Eye Health, and is the children's vision expert for the Office of Head Start's National Center on Health, Behavioral Health, and Safety, where she advocates for child eye safety, which she will be talking about with us momentarily. She is also a friend and a mentor and a role model for all of us in pediatric ophthalmology. And without further ado, I bring you Jean Ramsey.
Can folks hear me? Are we good?
We're good.
You can hear. All right. Well, Steve, thank you very much for that introduction. And I do feel like I'm among friends here with my colleagues and friends in Connecticut and also New York. And I don't know if any New Jersey folks are here, but it's great to be here. And the meeting is terrific, I have to say. Quite a potpourri here. So we're going to go into eye trauma from a lot of the discussions of surgery, et cetera. So thanks again for inviting me. And so what are we going to do today? We're going to start by looking at a number of clinical cases that illustrate injuries in both sports and also injuries in and around the home. After that, we'll look at some of the trends, take a broader view, check out the trends around pediatric eye trauma, and also see with the data coming out from the pandemic, if any of these trends are changing. And as you can imagine, they are indeed changing. And within the discussion today, there'll be consideration of how we can at least prevent some of these injuries from occurring. Here's a note for me to tell you: when you see 3 stars and it's some bold information following the stars, that's information that you may need to answer the CME questions, trying to make it easy for you all. So let's kind of set the stage. First off, a lot of children get eye injuries. In fact, they account for 1/3 of all the emergency department visits for eye injury. And the NEI states that this is the leading cause of vision loss in children. And the injuries that children get can be either put in the pot of sports injuries or injuries in and around the eye. So with sports injuries, most of them occur while they're playing sports. Lots of children play sports. And while certainly not life-threatening, some of them will have permanent visual loss as a result of the injury. And this is probably the biggest take-home part, and I know you've all heard this before. 90% of these injuries are thought to be preventable with protective eyewear and proper equipment, yet most of the leagues at this point don't require protective eyewear. So what about the injuries in and around the home? We like to think that our home is a safe place, and it is a safe place, but there are many things at home, especially if they're not supervised, can become weapons, especially for children. The young children can have serious eye injury, vision-threatening injuries from incidents around the home, incidents involving projectiles, cleaners, sharp-edged objects. An older child's toy that may be safe for them could be really a weapon for a young child. Injuries in the home can also involve the pet. And many of us have animals. 1/3 of the households have at least one dog. So dog bites, again, these tend to affect younger children. And injuries related to powered equipment. So you say, I don't have any powered equipment. Well, you may have lawnmowers, you may have hedge trimmers. If you live in the city, there may be some work going outside your door. So we have to be aware of all those sources that can create an injury. So let's go through some cases. I'm going to start with basketball. That's one of the sports that contributes greatly to ocular injury in children. And the good news is the ball isn't a great threat because it can't enter the orbital rim and it's hard, can't deform. So most of the injuries have to do with fingers or elbows. And of course, we all know that most of the skills that are used to play basketball occur at or above the face. So the inadvertent contact with the eye, with the face and eyes, is really unavoidable. The good news is that the fingers and elbows move relatively slowly. So we're not talking about projectile type injuries. Most of the injuries are blunt trauma, but serious injury can and does occur. So here's a case. A 10-year-old struck in the eye playing basketball, had a decrease in vision. By the time we saw him, he was NLP in his right eye with an afferent pupillary defect. He had a conjunctival laceration, hemorrhage, vitreous hemorrhage. When we looked at the retina, we saw box scarring of the vessels, attenuation of the arterioles, and where the nerve should have been, instead of seeing a nerve, we saw a defect in the globe where the nerve should have been. So what's the diagnosis? Optic nerve avulsion. This is where the nerve is disinserted traumatically from the globe. Most cases occur when a blunt object intrudes between the globe and the orbital wall, in this case, a finger, most likely. And in this process, the globe is rotated or pulled anteriorly, and the nerve is torn from the globe. So this is clearly a serious injury and a permanent injury, and an injury that certainly with eye protection would have been prevented. So what about soccer? The ball's smaller, but still too large to enter the orbital rim, but it can deform, especially under high velocity. It can deform and then strike the globe. A soccer ball, if underinflated, which I've been guilty of suggesting that the soccer ball be underinflated when doing soccer with young children. Clearly, that's not a good idea because it can deform when it enters the orbital rim and strike the eye. And children have incompletely developed orbital rims, so not a lot of protection there should they be struck by the soccer ball. So here's a case, and I'm sure many of you have had similar cases. A 6-year-old was hit in the eye with a soccer ball, noted pain and loss of vision. By the time we saw him, sure enough, had a hyphema. But there must have been a lot of momentum when the ball struck because there was also damage in the retina. Developed elevated pressures, had to be followed for quite a while, managed on 3 glaucoma medicines, ultimately did fine. But it was a difficult injury and can have permanent damage. Let's look at baseball. This is another category of sports that account for a lot of the injuries in children. Now, baseball too is too large to enter the orbit directly, but under a high velocity, it can fracture the orbital bones and then strike the globe. As happened in 2000, when a Red Sox pitcher was pitching to a Yankee player, it was a Red Sox Yankee game, and he got struck in the eye by the batted ball. Had a massive amount of facial fractures, orbital fractures, retinal injury, and was left with permanent visual loss. So in major leagues, most of the injuries are caused by batted balls. But in Little League, most of the injuries are caused by a pitched ball. And when you think of it, that makes perfect sense, right? Because you have a 12-year-old who probably looks more like a 14-year-old throwing balls, and they can reach a velocity of 40 to 50 miles per hour. And then you have a batter, probably younger than 12, that's not able to really get out of the way of a pitch that goes awry. So eye injuries are going to happen in baseball without protective eyewear. And at this point, as I read the Little League rules, it is not required, but they will allow protective polycarbonate shields or protective guards to be inserted on the helmet, as long as they abide by the standards. So this is really what needs to get done in baseball, and I hope more communities are doing this. I think this is the low-hanging fruit for all of us. What about golf? Well, fortunately, we don't have a lot of golf injuries, but when they occur, they're relatively severe because the golf ball fits nicely in the orbit, and so does the golf club. So when we look at the injuries, 32% of these patients suffered a blinding injury, ruptured globes, optic nerve injuries, so serious injuries. What about racket sports? So here we're talking about most of the trauma from a high velocity projectile. And I was unaware before I got into eye trauma that the shuttlecock can travel up to 200 miles per hour, but the racket can also strike the globe. And the racquetball is small and compressible and capable of striking the globe. These are open eyeglasses. This is what I wore when I used to play racquetball. So clearly, they're not appropriate because of the deformation that occurs on impact. These are the velocities of some of the sports, which many of you, I'm sure, engage in. And that, of course, is why we need polycarbonate lenses. And if folks haven't seen these pictures, let me just spend a minute. This is where a BB gun is shot through a lens. And we see on the left, the lens is shattered, a normal lens, and the BB gun goes through the lens. But with polycarbonate, it bounces off, and the lens is protected, and the eyes are protected. So let's talk about paintball. 15-year-old struck in the eye with a paintball. The vision was reduced, had some hemorrhage, high femur, had enough energy that the lens was subluxed, developed a cataract, had cataract surgery, glaucoma surgery, and ultimately the vision was hand motion. And that's not atypical. Of these 13 patients who suffered paintball trauma, a number of them had ruptured globes, retinal detachments, and a 5-month follow-up, 8 of the 13 had vision of 2200 or worse. So paintball clearly has a potential for severe visual loss. Now, if they go to a spot to have a paintball game, they're required to have facial and eye protection, and that certainly would be protective. The children that I've seen with paintball injuries, when I asked them how it happened, they said they lifted their shield in order to wipe their eye, and then they got struck. So clearly the shield should not be removed when in play. And maybe you're aware of, I was not aware, you can actually buy paintballs and use them for your own fun in your own backyard. So let me suggest that sports injuries, for a lot of the sports, are not accidents. They're predictable events, and most can be prevented with education, with equipment, and we would probably also need some regulatory changes. We know it can work because with enforcement of mandatory eyewear in high school and field hockey, the players experience 80% fewer eye and orbital injuries. Let's move on to eye injuries at home, a safe place. So here's a girl about 10 years old who came to the emergency room. And she had a full thickness marginal lid laceration that was sutured nicely and came to see me the next morning. So, and here's the history. She was jumping on a bed and she was struck by the overhead circulating fan. The kind of history that makes you a little bit queasy. So you want to look really carefully. And does anything bother you about this image here? What about here? There looks to be a superficial lid laceration, but given the history, we thought we would probe it. She was a great kid. We were able to probe it in the office. And sure enough, when we probed it, the probe appeared through the laceration. So that was a full thickness laceration through the canalicular outflow system. She underwent surgery and did fine, but a serious injury that could have been worse. We got a call from the emergency room. They had a 3-year-old who had been scratched in her eye by her cat. So again, you tend to think the worst, and she comes up and you're reassured. Looks pretty good. She's a good kid. We're able to examine her in the office, and we see that she has a conjunctival laceration. We were able to actually probe it with a moistened Q-tip. There was no signs of a deeper injury, and the eye exam was normal, so she did well. Here's a little guy. He was 6 years old when I saw him. He was struck in his eye by a pump-up rocket, and I assume it was something like this one here. And when I asked him what had happened, he said he was pumping it up and kept pumping it, and it wasn't moving. So he leaned over to see what happened, and the rocket took off and struck him in the eye. So when he presented, he had a hyphema. Wasn't a layered hyphema, was a diffuse hyphema. Oftentimes we see that in children because they move around a lot. And we treated him obviously for that. But let me say a few notes about this. Our academy says that projectile toys are not safe. So if you go to buy, say, a projectile toy, say this gun here, it will say that it's safe because there's foam pellets, Nerf pellets. But as the academy says, Nerf is soft, but that doesn't mean safe because it depends on the velocity that the object is traveling and how close the child is to the impact at the time. And with this case here, he was obviously very close to the rocket. So here is a 4-year-old that was referred for a foreign body, to say the least. So what was the history? The patient was jumping on the couch and fell onto a pencil. The trauma was unwitnessed. So here's another picture. They did an imaging. And here we see the entrance of the pencil into the orbit. And it traversed the entire brain to the skull on the other side. So this was a significant injury. And the child was neurologically intact. Child was taken to the operating room. And there was a whole team there, I was told, to include urology, neurosurgery, and gingerly the pencil was removed. And knock on wood, here's the pencil that was removed, and the child was neurologically intact. So child did well, and that was a very lucky child and family. So we talk about sharp objects in the home. Clearly, this is a little guy who had a significant corneal laceration. So the story here is the child and mom were chatting. The child was in the other room. Mom was in the kitchen peeling potatoes. And she wanted to address her child, ask him a question. So when she turned around at the sink, she didn't realize her child was in back of her, and the knife she was holding lacerated the cornea. The last case here is an unknown. 12-month-old was referred for a lid laceration and a hyphema. And the report was that the patient fell and struck her eye on a picture frame, and the trauma was unwitnessed. So sure enough, the patient had a full thickness laceration, had a hyphema, some injection. There was no bullous, subconj, heme, nothing to suggest a ruptured globe. So what's your plan? Repair the lid lac. Probably do an EUA while you're there. Anything else? Would you get a CAT scan? And you had a history that was consistent with the injury, right? Because that's what we look for. You know, if the injury and the history are not consistent, you begin asking questions. But there's another time that we have to ask questions, when the trauma is unwitnessed. And that was the case here. The trauma was unwitnessed. And because of that, we did get a CAT scan. And you'll have to believe me, we had no other reasons other than the unwitnessed trauma to get the CAT scan. And as we're in the suite that evening, watching the images come up, we were surprised. There was a foreign body in the left orbit adjacent to the globe. So Child underwent an orbital exploration and the foreign body was removed and was a BB pellet. Social service got involved, and it turns out the BB was fired by an 11-year-old playing in the house. So we know that BB guns have a high potential for eye injury. And now we're talking about eyes, not only with ruptures, but they're unsalvageable. 22 eyes with BB gun injuries, 19 were unsalvageable. And the reason, of course, is because they have the momentum, the velocity to enter the eye, but not to exit the eye. So a large degree of trauma. So the take-home point from this case, to me, is the need to, if you don't have a history, or the history hasn't been witnessed, certainly in a child, or even in an adolescent, that we need to proceed like we have no history at all. So now let's take a bigger picture, look at some of the data on trends in eye injury for children. Here's a 23-year study based on data from the US Consumer Product Safety Commission. It involves 500,000 children, which amounts to about 19,000 per year. And they looked at the rates of injury. And overall, during this period of time, the rate of injury did decrease slightly. And they felt this coincided with decreased participation in youth sports. In other words, nothing had happened to make any sports injuries less predictable. There were no interventions. It more had to do with the numbers who participated in the sports. So the highest rate of injury here occurred in the older children, 10 to 14-year-olds, 15 to 17-year-olds. And no surprise, because they tend to engage in the activities in which we find a lot of ocular injuries. The rate of injury for the 0 to 4-year-olds was significantly less, but we'll see that injuries in this age group tend to be more severe and vision threatening. So they looked at the rate of injury for the different sports, and we see basketball and baseball, again, the highest rate of injury, as we would expect. They also noted a decrease in the rate of injury over the course of the 23 years. Football was fairly stable in the rate of injury. This dark, bold line here represents non-powder guns. By non-powder guns, they're referring to BB guns, pellet guns, and paintball guns. And there was an increase by 168% over this time period, quite dramatic. Non-powder guns were responsible for almost half of the hospitalizations. Of this group, 79% were BB or pellet guns, 19% paintball guns. So for the 5 to 9-year-olds and 10 to 14-year-olds, baseball and softball were the sports most associated with injury in that age group. For the older age group, we're looking at basketball, non-powder guns. And for the youngest age group, 0 to 4, it's playground equipment and trampolines most associated with eye injury. This is no surprise, especially if you've been to a playground and seen these kids. Here's another study based on the largest database for the emergency department of the United States. There were over 300,000 children over an 8-year period. That was 42,000 children with eye injury per year. They too saw a decline in ocular injuries over time. Sports remained the most common cause of injury, but they also noted some significant injuries due to household and domestic activities. So within the house, young children were more likely to be bitten by a dog and sustain a serious dog bite. They found that children in this age group had the highest probability of suffering a traumatic injury that resulted in vision loss compared to the other groups. They felt this was secondary to some inattention in the home. I suppose there was a component of that, but combined with the domestic hazards that do exist in the home. These include household cleaners and pets, as we've seen, sharp-edged items, and they may be toys for an older child that a younger child shouldn't be playing with. Children's toys that incorporate projectiles. So all projectiles we know should be seen as very dangerous and to be used only with adult supervision. So what has gone on since the pandemic in terms of ocular trauma in children? So here's a study from Italy over a 1-month period in 2020. It was started at the date of the quarantine and compared it to data in 2019. So already we can see that the number of eye injuries was dramatically reduced. 354 in 2019, 112 in 2020. So all numbers were down. But the proportion of injuries in children was also down. So what was going on there? They noted also that sports injuries had the highest decrease from 2019 to 2020. Home activities and injuries that dealt with plants had the highest increase. So clearly there were behavioral changes, and sports eye injuries, responsible for most of the injuries in children, was dramatically reduced with the quarantine, as we would expect. Other studies have shown similar trends. In this Indian study, there were fewer patients who presented for emergency care, and home-related injuries were more common in the COVID period. 78% of the injuries, the majority of the patients, suffered home-related injuries versus 36% prior to COVID. Interestingly, there was an increased percentage of open globe injuries, and that would be interesting to look at and see if that correlates with the home injuries, because we're learning that home injuries can be more severe and vision threatening. The UK study over a 1-week period again, reduced numbers of patients being seen, increased in injuries occurring in the home. They pointed to gardening, home improvement projects, elastic bands, and the recommendation was that we need to increase our awareness of potential eye injuries that can occur in and around the home. And I suppose as we look back on the data from the pandemic, we may gather more information about what types of eye injuries occurred. And we could develop a better way to educate people around the need for prevention. I'm going to end just a few comments on hand sanitizer injuries. I think you've all heard about this. You know, with the pandemic, hand sanitizers were everywhere. A lot of them were alcohol-based. So here's a study from France, from the Poison Control Center data and data from a pediatric referral hospital. And they looked at alcohol-based hand sanitizer injuries. So overall, the percentage of children presenting with a chemical injury of any kind was about the same, 5% and 4%. However, more of these cases, there were more cases of alcohol-based hand sanitizer exposures. More of these cases were occurring in public spaces, 63 cases, whereas there were no cases in public spaces in 2019. And no surprise, because these hand sanitizer dispensers were placed wherever they were felt to be needed. Here we have a foot-operated dispenser that dispenses the gel right about the level of the child's face. So the placement of the dispenser can be a risk for a child. The cytotoxic effect of the alcohol can certainly account for the severity of the injury, in addition to the viscosity and the delay in eye washing. So because of this, they saw more patients admitted to the hospital for treatment of alcohol-based hand sanitizer exposure. Many of them had large corneal and epithelial defects. involving more than 50% of the cornea. 2 of them needed amniotic membrane transplant surgery, but a lot of them still did well. So in terms of prevention, we need to ensure that in our practices, in our homes, that there's safe use of these alcohol-based agents, and counsel our patients and staff about how they're used. So with that, I'd just like to spend a minute here and summarize some of the key points. One of the take-home points for me always is that the history is always important, but especially when you're talking about pediatric traumatic eye injury, it's critically important. And if it hasn't been witnessed by a reliable source, then we assume there's no history. Sports account for the majority of PD eye injury, and nearly all of these injuries can be prevented with protective eyewear and prevention strategies. At-home injuries also play an important role in eye trauma, especially in our younger children. And eye trauma at home in young children had the highest probability of vision loss. During COVID, fewer patients presented for emergency care. There was a decrease, obviously, in sports-related injuries and an increase in the proportion of traumatic injuries occurring at home. Surgical attention, we should all pay special attention to the risk around our alcohol-based hand sanitizers. So with that, I will end it, and I thank you all and have a great meeting.
Thank you, Dr. Ramsey. It's a pleasure to have you as part of the program. If you have questions for Dr. Ramsey, please submit them under the question and answer or chat boxes. And Dr. Ramsey, if you'll just take a moment to go through those and see and answer the questions from our audience. We'll move on to our next speaker, Barry Cooperman, the Department Chair of Ophthalmology at the University of California, Irvine. He's a known leader, teacher, researcher, and innovator. And he's going to speak about neuroprotection and neuro enhancement with a look into the future. And he'll also address clinical decision-making in the management of diabetic macular edema in his talk titled Neuroprotection and Neuro Enhancement for the Treatment of Retinal Diseases and the Role of Inflammation in DME and Impact on Clinical Management. Thank you, Dr. Kupperman, for joining us this afternoon.
Thanks, Dr. Lim. Should I go ahead and share my screen?
Yes, please.
Okay. Well, thank you. It's a pleasure and an honor to be here. I'm reporting from the other coast. Actually, interestingly, just this second, it almost interrupted us. My cell phone just went off with an alarm of a tsunami alert because of the volcano in somewhere in the Western Pacific that there's now a California, it's the first time I've ever gotten a tsunami alert on my phone. So I'm high enough off the ground. I look at the ocean, but from a high vantage point. So I'm assuming we're fine here. But again, thank you for the kind invitation to speak here today. It's been a great meeting. I've been enjoying listening to things. And again, I will give 2 back-to-back talks. I'll stop in between for questions as desired. Again, I'm the chair of the Department of Ophthalmology at UC Irvine. Here are my financial disclosures. And for a brief moment, I just want to acknowledge Neil Patel, who was our fellow some 11, 12 years ago. And he passed away in New York as a New York practicing ophthalmologist last week, and his services were this week. So I just want to acknowledge him. He was a unique individual. We really enjoyed him. He was trained he's from the East Coast, trained there, but came to California for his fellowship, and want to acknowledge and wish my condolences to his family. So, let me start talking about this, the whole issue of neuroprotection. What we want to do is stop retinal cell death. That is the challenge that we have, because again, there's this process that various factors promoting either cell survival or death of the retinal neurons and protectors, photoreceptors rather, and we're trying to balance out these pro-death signals from these pro-survival signals. And neuroprotection, the goal is to tip the balance in favor of cell survival. We want to block the cell death signals and enhance cell survival signals. It's not advancing. There we go. And cyto and neuroprotection. We talk about cytoprotection too, because we're trying to prevent the retinal pigment epithelial cells from dying, so they're not neuronal cells. But the whole goal of it is actually, and again, we're going to see, and I'm going to discuss products that are in development now that should potentially soon be in the marketplace, but this is relevant to those, the complement inhibitors. We're trying to prevent the cells from dying off. So again, we're slowing down the rate of cell death. That's what neuroprotection is. And you can see here this curve, the rate of cell death in blue, normally natural history, and in orange, it slows down the rate of cell death. I'm also going to talk briefly about neuro enhancement. The difference between neuroprotection and neuro enhancement is that neuroprotection reduces the rate of cell death, again, as I mentioned, for photoreceptors and retinal pigment epithelium in the retina. Neuro enhancement actually improves the function of the surviving cells, which improves retinal function and theoretically could increase vision. And I'll discuss a couple of products with that goal in mind. Again, the role of there's a significant unmet need for both neuroprotection and neuro enhancement in the posterior segment for a lot of conditions: diabetic macular ischemia, chronic macular edema, retinal detachment, dry macular degeneration, geographic atrophy, and retinitis pigmentosa. And there's many pathways that have been explored. Many of these have not succeeded. I will focus on the three in bold: complement inhibition. There are two products that you may have heard of that are in phase 3 testing. One is completed phase 3 and going to the FDA, and I'll discuss those. I'll talk about integrin peptide inhibition, and again, mitochondrial membrane stabilization in this talk. Complement has been found in dry macular degeneration, mostly located in the drusen. There's been clear evidence of complement components in dry macular degeneration in the drusen component. And there's been a lot of studies looking at the goal of suppression of inflammation via complement inhibition of complement, including C3 inhibition and C5 inhibition, are actively underway by Apellis and Iveric Bio. Others have failed. All these others have largely failed. So again, it's still an open question as to how successful this will be. We do have data, though, that does suggest that it is significantly successful. And again, there's these complement pathways leading to geographic atrophy. There's the lectin pathway, the classical pathway, and then the alternative pathway, with a focus on C3, which is in this case the Apellis compound that inhibits C3, which then stops the further cascade of events leading to C5 and MAC. And so the goal is to stop cell death. In this study, the Philly trial originally was done, and again, this product was injected either monthly or every other month in people with geographic atrophy, and it showed that in the monthly population, a reduction in growth of the geographic atrophy by 28.6%. Again, so that was a success. It's worth noting this is for slowing down the rate of cell death, and that's what this product does, and it required monthly injections for the most effective result. You can also see in this analysis of that Philly study, the phase 2 study, that the effect wasn't seen so much in the first 6 months, but rather in the second 6 months. So then you can see it time 0 to 6 months, not much. You can see the effect, the impact more prominently in the second 6 months, months 6 to 12. The bad news is that vision still continued to deteriorate. So this is going to be a challenge for us as retina specialists. We're used to giving anti-VEGF injections on a frequent basis, monthly, every 4, 6, 7, 8, whatever the treat and extend parameters are for that individual, whether that's for wet macular degeneration, diabetic macular edema, retinal vein occlusion. This one is different. We're not really going to see a wow effect. We're going to prevent the progression of disease. And in this study that went out to ultimately 18 months, there was no change in vision loss here, though we anticipate seeing that over a period of years. But again, this is monthly injections without any visual benefit. So it's going to be interesting to see how well embraced it'll be, even though we're all excited. This is a huge unmet need, and there's no treatments for dry macular degeneration, and certainly not for geographic atrophy. There was in the Philly trial, again, the C3 inhibition of Apellis, some development of wet macular degeneration that seemed to be associated with the dosing. Again, they call it exudation because it was pretty mild, but it was wet macular degeneration that did require anti-VEGF injections. You can see the sham column over here. It was a relatively low rate of natural history of development of exudation, but you can see it was dose dependent. When it was given every other month, it was 9%. When it was given, there's the tsunami alert again. Interesting. And 21% in the monthly dosing. Also, it's worth noting that there was a slight increase in endophthalmitis. Part of the complement pathways to prevent infections. We're wondering whether that's associated with this, but we're not yet rushing to any judgment here. We're just duly noting all this information. I think the marketplace will help us sort this out. Then subsequently, there was a phase 3 trial, two phase 3 trials, Oaks and Derby. And this is where things get a little more complicated, as if it wasn't already. Again, a history of not much success with complement inhibition after several, then the Philly study was successful, then the phase 3 study was done. And what happened is that one of the two phase 3 studies did show a benefit. Here's the Oak study, which showed when it was injected every other month, 16% reduction in growth of geographic atrophy lesions. And when it was injected monthly, 22% inhibition. And so relatively corroborative of the extensive phase 2 study, Philly. But the Derby study, the other of the pivotal trials, did not reach its endpoint. Again, every other month was an 11% reduction. Monthly was a 12% reduction in lesion growth. So it's going to be an open question as to how the FDA will address this. Of course, the company is optimistic. We just don't know what will happen. You look at the combined analysis of the pooled data, you can see that every other month injections resulted in a 14% reduction in growth, and a monthly injection 17% reduction. If you then look at, there's a couple of other analyses. If you look at compared to the fellow eye, there seemed to be an impact, again, slower growth rates in the treated eye than the fellow eye. And finally, if you look at extrafoveal lesions, there was an even larger effect, 26% monthly reduction with monthly and 23% reduction in growth when the lesion had not yet entered the fovea. Finally, with exudation, as they're calling it again, for development of wet macular degeneration, there again seemed to be a modest impact here, not quite as pronounced as was seen in the phase 2 study. And again, there was low incidence of endophthalmitis measurable, but there. So again, it's an open question as to what will happen. This is the compound that is now before the FDA, and we're looking forward to hearing those results from the FDA sometime this year. The other compound that's been looked at carefully has been a C5 inhibition inhibitor further down the complement pathway, and that's by that's called Zimura. That's by the company called Iveric Bio, used to be called Ophotec, New York-based. And again, it's an oligonucleotide with a pegylation attached to it. It's similarly been given either every month or every other month. And you can see here that in the GATHER1 study, the primary efficacy endpoint was achieved with, again, a 27% reduction in growth rate at this 2 milligram dose. They've looked at several doses, and the 4 milligram dose was 2 injections, was not significantly different. So they're going to, in the second phase, this was a phase 2/3 study, but will count as a pivotal trial. In the GATHER2 study, the other pivotal trial, which is underway, they're looking at just sham versus 2 milligrams. And again, it was well tolerated through month 12, no adverse events. There was no real inflammation. There was no case of endophthalmitis, but there was, again, a mild amount of exudation or choroidal neovascularization, wet macular degeneration that seemed to be somewhat dose dependent. So we're going to have to learn more about this if and when these products are approved and make it to the marketplace. But again, it is exciting in that there is no treatment for any aspect of dry macular degeneration, really. I mean, the vitamins do help the conversion from dry to wet, but not so much for the development of progression of dry. There may be some evidence of that. This is the first direct treatment for geographic atrophy, these two compounds. Again, GATHER1, the Iveric Bio compound, Zimura, is still under development. We'll have to wait and see what the second pivotal trial shows. The Apellis compound is, again, before the FDA. So again, in the Zimura compound, there was efficacy. It was reduced 27% reduction in growth of geographic atrophy over 12 months. And we'll have to, again, see what happens in the second phase 3 trial. This first one was a combined phase 2/3 trial. Next, I'm going to shift focus to go to actually Neuro Enhancement. This is a different sort of compound. This is a different study. It's still very early. There is data. This is a company that's actually locally based here in California, in Irvine, actually founded by a former chief resident of ours, Victor Taragosian, with his father. Small company, but it's being developed, the Bisutigimab. It's a RG class peptide. So this is integrin. It's part of the integrin pathway. It regulates integrin functions. What does it do? It seems to reduce oxidative stress. It has anti-angiogenic effects. It has anti-inflammatory effects, and it stabilizes mitochondria. And there's going to be another compound I'll talk about next that also stabilizes mitochondria, and that decreases apoptosis, that programs cell death, increases retinal cell survival, and enhance mitochondrial health. So these may be key functions to improve visual function. That is not only stopping death, but providing some neuro enhancement. This was an unusual study in that it was asymmetric. They gave the compound rizuteganib 1 milligram at baseline and again at week 16. In the sham control group, they gave one injection only at week 16, and they compared the results at week 28 in the treated group to the sham results because we're looking for improvement in vision. And again, these eyes tend to deteriorate over time. So again, this goal of this study is to see how many eyes could improve in vision. And the answer was, if you looked at 8 letters gain, which the FDA has asked for these sorts of compounds to not only inhibit a loss of vision or inhibit the growth of a lesion, but now to increase vision. And in fact, 48% of eyes gained at least 8 letters, and compared to 1 out of 14, 7% of the sham group. And if you look at this waterfall plot, you can see the distribution of these eyes. You can see all the eyes shifting to the right were the ones with the treated group, with the exception of that one. And if you look at a more difficult test, those of getting either 10 letter gains or 15 letters gained, 32% of these patients got 10 letters gained and 20% got 15 letters gained. So again, this is very promising. It's the first study that showed really improvement in vision in this population. This is with dry macular degeneration before the onset of significant geographic atrophy. There might have been a small amount of focal geographic atrophy, but no significant geographic atrophy. Again, looking at those with dry macular degeneration primarily. And again, there was no significant adverse effects. And again, these are injections that are given every 16 weeks or so. So again, that's promising, and that it's a less frequent injection. So this is still under development. The company's small. It's getting resources for development of a phase 3 trial. But again, it's been looked at for diabetic macular edema, wet AMD, and now dry AMD. And again, so there's a lot of patients who have been treated with this. These results look the most promising. And again, the company is developing a protocol for a phase 3 trial. I'll now talk about another compound called Lamipratide, but it's based on what it does to the mitochondria. Macular degeneration is characterized by marked mitochondrial defects with extensive loss of cristae, ghost mitochondria, and mitochondrial dissolution with bleb formation. You can see there in the arrow right here. So again, there's a lot of destruction that happens at the level of the mitochondria in patients with macular degeneration. Lamipratide, it stabilizes the cristae architecture, and basically it's stabilizing the inner mitochondrial membrane. So it stopped this destructive process, this degenerative process from progressing. And again, you can see in these photos, you can see a normal cristae on the left. You can see disease state 1 and a restored one after a Lamipratide. This compound is a little complicated because it's a subcutaneous one. It has to be an injection and daily. So again, it's associated with its own hurdles as it tries to consider itself for the marketplace. But they've done a couple of studies looking at high-risk drusen and non-central GA. And what they showed was that there was, in regular light vision, they showed a benefit in both groups, drusen as well as GA. The low light vision, again, a benefit was seen in these two groups. If you look at, if you focus on non-central GA, sorry, this was for if you look at for non-central GA, is what they're going to be pursuing in their next study, Reclaim 2. Again, it's going to be given once daily, subcutaneous injection versus placebo, and that study is underway in accruing patients, and they'll look at these various efficacy endpoints from low luminance vision, low luminance reading, best corrected visual acuity, and again, a variety of other endpoints. So I'll conclude here just to say that there is a huge unmet need for neuroprotection, neuro enhancement for retinal diseases. It's still a struggle. It's not an easy situation. Neuroprotection, again, focuses on slowing down the rate of cell death, and that's what's being looked at with these complement inhibition here for geographic atrophy. So these are the ones, particularly when it comes to the Apellis compound, it's closest to the marketplace. It's completed its phase 3 trials. It's in front of the FDA now. But again, it is just to set the expectations. It's going to slow down the rate of cell death. We have yet to see any impact on vision loss over time, but we do see it for lesion size growth. So it should be associated over time with decreasing the rate of vision loss. But it's a challenge. It's going to be either monthly or maybe every other month. They're trying injections. They're trying to come up with drug delivery strategies. But again, this is something that's going to be available sometime this year, and will be a discussion between the company and the retina specialist community, and then the patient community to see which patients are appropriate. And again, it looks promising. Reduction of growth rate is about 25% or so over the course of a year. Is that enough to be compelling to patients? We'll have to wait and see. I mentioned integrin peptide inhibition. That's earlier in development, but what's exciting about that is that it actually increases vision because it's, again, a mitochondrial membrane stabilizer besides having its other effects. And again, lamipratide is specifically a mitochondrial membrane stabilizer. Even earlier on, it has the downside of being a daily subcutaneous injection. Again, integrin peptide inhibition, that compound, rizutigimab, is injected every 12 or 16 weeks. So that's the most appealing from a drug delivery standpoint. There's other work being done of these others. There's also neurotrophic stem cells that's being done, a lot of other work. So there's a lot of excitement in this field. And again, the biggest excitement is that there is a compound that is potentially going to be approved by the FDA this year. We'll have to see how that plays out in the marketplace with its both benefits and limitations. Thank you very much for your attention. I'm glad to address any questions there may be for this section of the talk before I go on to the next talk. I'm sorry, I can't hear anything.
Yeah, I think you can go ahead. I don't see any questions being posed here in the
Okay.
question box.
All righty, so the next talk is on the role of inflammation in diabetic macular edema and the impact on clinical management. Again, my financial disclosures, and again, my condolences to Neil Patel's family. So what I'll be discussing in this segment of the talk is the role of inflammation, diabetic macular edema. I'll be talking a bit about biomarkers, which we're always struggling with. How do we decide which eyes should be treated with what? The efficacy of anti-VEGF agents versus corticosteroids, when we should switch, what are the criteria for switching? Again, we tend to start with anti-VEGF, but there's clearly, in my mind, a point at which we should consider alternative strategies. And I'll discuss briefly at the end a diabetic macular edema treatment algorithm. So again, what's interesting about this discussion, this is really an anti-VEGF world. The retina for the retina specialists out there, that our lives were changed dramatically in 2005, and our patients' lives were transformed because of the advent of Avastin, which first came along in 2005, and then shortly thereafter in 2006, along came Lucentis, and then subsequently Eylea. And for wet macular degeneration, it's been great, meaning we're looking for even better compounds. Faricimab is likely to be approved this year. There's now the port delivery system. There's all sorts of advances. And again, there is no good alternate strategy currently for wet macular degeneration, nothing viable yet. It seems to be primarily anti-VEGF based, and our successes have been unequivocal. When we get, not every patient benefits, but the overwhelming majority do. There's still vision loss. There's still more we want to do, but the success story for anti-VEGF compounds and for the treatment of wet macular degeneration is remarkable. And in fact, it's also remarkable for retinal vein occlusion and for diabetic macular edema. But it gets a little trickier when we talk about diabetic macular edema, because there is a significant subset of our diabetic macular edema population that actually doesn't respond particularly well to VEGF inhibition. In this sort of the Diabetic Retinopathy Clinical Research Network has been this key community-based network sponsored by the NIH, the NEI, and has sites all over the country. And we design all these protocols ourselves. But there was a very important one about a decade ago, DRCR Protocol I, which compared ranibizumab given with immediate laser, ranibizumab with deferred laser, triamcinolone with laser, and laser alone. But half of the population in that study got ranibizumab. The ones that had the deferred laser basically never got laser. Most of them never got laser. But in that study, looking at patients with diabetic macular edema that were getting ranibizumab, you look at the left, only about 50% showed an early and consistent response. You look at the far right, 23% were dubbed non-responders, and then an additional 12.5% were slow and variable, and then 15% were early but inconsistent. So again, we've seen this in a number of studies, as I'll show you, that the response to anti-VEGF, while is marked and good in many patients, it's not ubiquitous. And we think that the reason for that is because of inflammation. We know that inflammation is a key component of diabetic macular edema. Hyperglycemia causes oxidative stress, causes local inflammation with activation of microglial cells and dysfunction of the Mueller cells. And then the release of these inflammatory mediators, the cytokines and chemokines, including VEGF. VEGF is part of this cascade. That then leads to chronic inflammation, the capillary damage that we all learn about, the endothelial cell thickening, and the parasite dropout. That leads to disruption of the blood-retinal barrier, and then finally to vascular leakage and macular edema. And there's a lot of evidence to support this role of the other cytokines. It's very interesting. If you look in the study by Dong et al., looking at aqueous humor levels, and again, we prefer vitreous levels, but it's not as easy to get those. But if you look at the ETDRS retinopathy severity scale, which is that weird arcane, 10 is basically no or minimal retinopathy. By the time you get into the 60s, that's proliferative diabetic retinopathy. 75 and 81 are high risk proliferative diabetic retinopathy. So if you look at cytokine levels within the eye and the aqueous in eyes with diabetic retinopathy, and you see the severity scale, it's another way to think of the severity scale is time, because over time, people tend to get more severity of their retinopathy. So the severity scale is kind of a surrogate measure of time. I think of it that way. But if you look at the VEGF levels, it's clear that they're important. They're high all the time. In fact, what I don't show here is a different slide that if you look at non-diabetics, the same VEGF level would be under 100. So it's almost binary. When they're non-diabetics, have no retinopathy, they're down under 100, and then there's a switch that goes off, and they suddenly go to a very high level of VEGF. But interestingly, it doesn't seem to be sensitive to retinopathy severity, and therefore implicitly to time as well. So again, VEGF is clearly important, and you can clearly see these high levels. But if you look at the other cytokines, the interleukins, MCP1 is monocyte chemotactin protein, IP10, they all start low and go high over time. So when the disease is more chronic, you have a very high load of the other inflammatory cytokines and chemokines, and that's maybe competing with the VEGF levels. And why that's important is that this study, I love this study, it's a little tiny study of 11 patients, treated the most simplest way. It's a bilateral diabetic macular edema. One eye was injected with triamcinolone, the other with bevacizumab. And there's a lot of things that aren't very surprising here. The eyes with triamcinolone, treated with triamcinolone, had reduction in most of the inflammatory cytokines. It didn't look like it did much for IL-8, interleukin 8. And again, we know that it reduced VEGF. We know that steroids are good, but not great VEGF inhibitors. On the bevacizumab side, it's also, the bottom line is not surprising down here at the bottom. Bevacizumab is a great VEGF inhibitor. It reduced VEGF levels by 99%. What is surprising, though, is all the rest of this column under bevacizumab. When you reduce something as dramatically important, as we all acknowledge, VEGF inhibition is very important in these eyes. It doesn't do anything to any of the other inflammatory cytokines. There's no upregulation, no downregulation. This is neither downstream or upstream. We just see it's almost like two parallel pathways, no impact on the other inflammatory cytokines. So that makes us think a bit differently. If bevacizumab is such a single bullet, it is dramatically effective at reducing VEGF levels, but it doesn't do anything for the other inflammatory cytokines, and yet there's evidence that those inflammatory cytokines may be important in many eyes. It makes us think a bit differently about how we should manage our patients. And this cartoon is meant to imply, I could have made this with a box. VEGF really should be a rectangle here in that it's always high. But what I meant to say was the relative ratios of these two. Sometimes you have eyes with a lot of non-VEGF mediators. Those tend to be more chronic disease, we think, as I showed you from that table of Dong et al. Then there's eyes that have disproportionately high levels of VEGF inhibition. The ones over here to the right would be very responsive to anti-VEGF agents. The one on the left, much less responsive. And it's worth noting as part of the thesis of this talk is that steroids seem to be effective at treating both types of patients. And that's where I start thinking about when to use those. And let me show you some data to support that. There's a couple of drug delivery, steroid drug delivery products. Ozurdex has dexamethasone in it. That's the most popularly used one, but also the Evulsion, it's by a company called Alimera, has a fluocinolone implant that lasts for about 3 years. And that delivers, again, fluocinolone chronically over a prolonged period of time. But in their pivotal study called the FAME study, they looked at the duration of macular edema prior to entry in the study, and then looked at the responses. And in that study, either got the Evulsion implant or you got sham. But the study was designed so that within 6 weeks, if you saw no response, you could treat at will. And most of those patients in the sham group got treated with anti-VEGF agents, particularly bevacizumab. So the yellow line here, the sham control group became a surrogate for VEGF inhibition. And when the disease was less chronic, again, the median duration of macular edema prior to entering the study was about 2 years, 1.7 years, let's call it 2 years. On the left-hand side, you can see that steroids and, again, a surrogate for anti-VEGF agents, for bevacizumab on the left, you showed a comparable result. On the right-hand side, when the disease is more chronic, you can see that the steroids in blue still were very good. This fluocinolone did very well, but now the sham control group suddenly did not nearly as well in terms of getting a 15-letter response, which is what was being looked at. So again, it looks like, and these three curves are roughly the same, the two on the left and the blue on the right. They're not different from each other. The outlier is the sham control group, which again was largely treated with bevacizumab when the disease was more chronic. And there's further evidence of this. The pivotal trials that led to Lucentis, ranibizumab's approval for diabetic macular edema, were dubbed the RISE and RIDE trials. And again, in that study, it was monthly injections, and you can see the two doses, 0.3 and 0.5 milligram, you can see in white and turquoise, those dramatic lines of improvement, 12 letters gained. But what I'm focusing on here is the sham control group. When in those days, unfortunately, we didn't yet have an approved product. So for 2 years, patients were in the sham control group were given sham injections. We hated it, they hated it, but that was part of the study design necessary to prove its efficacy. And you can see that when eventually, finally, after 2 years, we were able to give the patients what we wanted to, that is ranibizumab, there was basically no response. It was a fully blunted response. The disease had become so chronic that they no longer responded to VEGF inhibition. Why is that? We don't know for sure, but we think it might be because of the thesis that I've presented to you, which is that all the other inflammatory cytokines had mounted up to higher and higher levels, and VEGF inhibition is a single bullet. It reduces VEGF levels, but not the levels of the other inflammatory cytokines. And there's further evidence too. If you look at the RESTORE study, this was one where there's a crossover of the control group in green at 1 year rather than 2 years. And rather than it being zero response, again, the yellow and orange, or the two oranges, kind of funny colors, are ranibizumab alone versus 0.5 versus ranibizumab plus laser. But you can see the green line, when there was switched over to be given ranibizumab after 1 year, gradually caught up. So there was a blunted, if you look at the slope of the curve at the beginning here, when ranibizumab was started initially, much steeper, much more responsive. Then when you finally do, after a delay of just a year, it's a markedly blunted curve. It's not a flat line, but again, it's the rate has really slowed down. It took another couple of years to catch up. So we can see this impact of this inflammatory cytokines, again, my thesis on this, within a year and maybe even sooner than that. So again, it's worth noting that if the disease is more chronic, it may not be as responsive to VEGF inhibition in our patients with diabetic macular edema. And we certainly know that something like a third of our patients will show what's called a suboptimal response to VEGF inhibition. That is a third of our patients with diabetic macular edema. We don't really know how to predict though. How do we know? Again, even though I do use steroids as a second-line therapy and I'm more aggressive about it than many others, I still start essentially all patients with VEGF inhibition. But if there were biomarkers, would they help guide us? And so there's a desperate attempt to look at biomarkers. We've talked about drill, disorganization of the retinal interlayers. We've talked about hyperreflective foci and trying to glean information from those. The hyperreflective foci have been shown to be, depending on their dimension, if it's less than 30 microns, and depending on their location, they may be activated microglial cells. When they're larger, they may be hard exudates. If they're in the outer retina, when they're in the retina, they may be microaneurysms. So we're trying to learn more from these biomarkers from these hyperreflective foci, but we still don't know enough about them. The hard exudates do seem to be a somewhat effective biomarker. There's a lot of there's several studies that have shown that there's the Dex implant, Ozurdex, which I tend to use when I do consider steroids. That's my first line choice after I've tried VEGF inhibition in most of my patients for diabetic macular edema. And it looks like Dex implant does a better job of clearing the hard exudates compared to anti-VEGF inhibition. So that may be a relative biomarker of use. So again, we don't really have effective biomarkers, but we're busy looking for them. It's very hard to predict. Again, many of us think by history, we ask the patient, or is there a history that we can help guide us? Do we start with anti-VEGF in that patient, which is the answer is typically yes. Or on the rare occasion, is this an eye that we'd rather start with corticosteroids because they exhibit signs of chronicity, but it's not clear that our sense of what is chronic is accurate or not. We're still looking for biomarkers. So what about the DEX implant? Again, the favored treatment, of course, is VEGF inhibition. There's the big three of Avastin, Lucentis, and Eylea. There's been some evidence from the RCRnet Protocol T that Eylea, aflibercept seems to be a bit more effective, certainly than Avastin in the first year. And there's some catching up in the second year, and the Lucentis is somewhere in between. But the DEX implant, Ozurdex, does a very good job as well. There's a host of studies that have looked at this in real life, 2 to 3 injections in a year with 6 to 9 letters gained. Here's a bunch of real world results for DEX implant. And again, here's even more that there's a huge amount of literature looking at the DEX implant in real life. And just to focus on in the real world rather, and then just to focus on a couple of the studies. Here's one, Escobar Barranco, 76 patients, 40 with refractory, that is a previously failed or had a suboptimal response to anti-VEGF inhibition, 36 treatment naive. And you can see that the time to treatment naive recurrence is 5 months, and the refractory was 4 months. I would say typically in my hands, I have to re-inject about every 3 to 4 months with the DEX implant. But again, that tends to be a longer duration than our patients getting anti-VEGF injections. Here's another study, the Agrel-Dex study, 130 patients, and you can see here 11.3 letters gained in treatment naive, 7.3 in those refractory to VEGF inhibition. You can see how well their drying occurs. The DEX implant steroids do a dramatically good job of drying the macula. I should mention the VEGF inhibition, while the vision can be good, a lot of times those are in eyes where they don't get completely dried out. The steroid DEX implant does a remarkable job of drying out the macula. And here's the Invictus study, which was actually a head-to-head. It compared ranibizumab to aflibercept to DEX implant, and they showed comparable results for all three with much less frequency of injection of the DEX implant, even taking account, of course, that steroids and why we use it as second-line therapy is the risk of intraocular pressure elevation and cataract formation. So that's always something we have to take into account, which is why it tends to be second-line therapy, not first-line therapy, given this good data. So again, when do I switch? I do want to make it clear, even though I'm a happy user of steroids, particularly DEX implant as my first-line choice for steroids, I should say, but it's my second-line choice. I start with anti-VEGF most of the time, but what I do differently, I try to do in a thoughtful way, is deciding when to switch. And this is a DRCRnet Protocol I again, but what they did is, again, patients got the ranibizumab group, they got injection at time 0, at 4 weeks, and at 8 weeks, and they came back at 12 weeks after those 3 baseline injections. And then we looked to see what the response was, and then follow them in those groups. So there was about 40% of patients in red here that had less than 5 letters gained, then that was the poor responding group, at least in the early going. Then 37% in blue that had the significant gain, they had at least 10 letters improvement. And in between group was 23% in green that gained between 5 and 9 letters. And we then put them into those groups and follow them over time to see what happened. Did, for example, the group in red show improvement over time? And what happened is that they developed these so-called swim lanes. The group that did well at the beginning in blue stayed in good shape. Those that after 3 injections had only 5-letter gain never really crossed over. The rate of the people going from the red line to the blue line, the desired line, was over 3 years was less than 30%. So again, they tend to develop swim lanes, and this was after the first 3 injections. So after the early going, after 3 injections, there's a lot of data that you can have to make a decision as to whether you want to keep giving anti-VEGF injections versus switching over to another treatment approach. And in my mind, that would be DEX implant. This was corroborated with the Protocol T study. It was a bit noisier, but you can see for the ranibizumab group, the aflibercept group, and the bevacizumab group that the early going was determinative of how they did over time after 3 injections at 12 weeks. And finally, the Bush study was a very clever one where they compared real-world outcomes of continued anti-VEGF therapy versus switching to DEX implant after month 3. So again, 3 monthly anti-VEGF injections, then if they were refractory, there was still suboptimal response, they either switched to DEX implant or continued on anti-VEGF therapy. And what was shown, you can see that the 6 letters gained here, the better curve, is the ones that switched to DEX implant. Those that did not show any improvement in black were the group that was maintained on anti-VEGF agents. You can see that those getting the DEX implant on the right had better drawing as well. And finally, you can see here this meta-analysis of 3,800 patients, a bunch of studies that all had got a series of injections of anti-VEGF agents with suboptimal response, then the patients were either continued on anti-VEGF versus switched to DEX implant. In all the studies, you see the shift to the right. They all favor the DEX implant on the right. Some statistically significant, others not, but you can see the trend here. It's all shifting to the right. None of them shift to the left at all. That is favoring DEX implant, switching to DEX implant when you encounter a suboptimal response. I'll just show you an interesting case study that I gave at a course with Anat Lowenstein and Michaela Goldstein from Tel Aviv, but I find it very illustrative. A 65-year-old female, right eye, regressed proliferative diabetic retinopathy status post panretinal photocoagulation. The left eye has severe NPDR. Both eyes have diabetic macular edema, the right eye much more than the left eye. The right eye has already gotten focal laser. The right eye has already gotten bevacizumab ×3. And then you can see here the fluorescein angiograms and the OCT. So this OCT in the upper left is the right eye after 3 bevacizumab injections. That's a pretty poor response. They gave another 3 bevacizumab injections. So now this is 6 bevacizumab injections on the right. On the left, you can see here in the left eye, you can see the beginning of diabetic, of intraretinal fluid. They didn't yet treat there, but you see that later on it progressed as they're observing the right eye. So what happens at the point down here, the right eye was given DEX implant. And you can see 1 week after the DEX implant, Ozurdex, the drawing, you can see it 4 weeks later and 11 weeks later, this remarkable drawing, really fantastic. At the point that the right eye was given the DEX implant, the left eye had really progressed dramatically. So they'd made an interesting decision, which was instead of treating that left eye with bevacizumab first, given that the right eye had failed so poorly, they decided to give a DEX implant as primary therapy. And in fact, they show this beautiful response of DEX implant after 1 week and then after 8 weeks. So I just want to also mention briefly how to manage diabetic macular edema with regards to cataract surgery. When you operate, you try to treat a dry macula prior to surgery, use anti-VEGF agents versus steroids versus no supplemental therapy at either before the surgery or after the surgery. How do you follow them up? I don't have much to say. I mean, I have lots to say about that. That's not the focus of this talk, but just to focus on one paper, Agarwal et al. Looked at timing of, they did randomized patients either get no therapy or a DEX implant on time of cataract surgery. And you can see here, here's an eye that had diabetic macular edema at baseline, got cataract surgery, got a DEX implant at the same time, and this is what it looks like 12 weeks post-op. And conversely, here's one that at baseline, we didn't really have any diabetic macular edema, had some diabetic retinopathy, you can see, but no real macular edema was observed and did not get any DEX implant. You can see the edema that developed 12 weeks later. So it's just worth noting that at the time of cataract surgery, there's some decisions that need to be made, whether you use anti-VEGF agents or a DEX implant is debatable. So I'll just close briefly with the DME treatment algorithm to point out that it's complicated. This is from the European Retina Society of the Retina, and it's just showing that diabetic macular edema is a very complicated disease. You have to worry about the vitreoretinal interface. Sometimes we consider surgery. We mostly start with anti-VEGF, but steroids have a role. It's just a complicated disease and requires a lot more thought. The reality is for wet macular degeneration, we tend to mostly just give anti-VEGF injections. Big debate is with what frequency do you do, extend or PRN or regular treatment. With diabetic macular edema, there needs to be a lot more thought to the process. And when I do think about the DEX implant in my patients, again, this is when I think that it's time to switch from anti-VEGF to DEX implant. I think about in pseudophakic eyes or eyes scheduled for cataract surgery, because one of the big risks of steroid implants of DEX, of any steroid, is the development of cataracts. If I see a suboptimal response after somewhere between 3 to 6 anti-VEGF injections, regardless of phakic status, and I will consider it in the fellow eye. If the fellow eye had a poor response to anti-VEGF, I will accelerate that timetable. A vitrectomized eye, when the eye is vitrectomized, anti-VEGF agents work, but they have a much shorter duration. Eyes with extensive exudates, that may be a sign of chronicity. And again, there's evidence that DEX implant clears those exudates faster than anti-VEGF agents. Chronic DME that is not responsive to other treatments, but how do we recognize chronic DME? Patients with a recent MI or stroke, again, we know that diabetics have a vascular disease. They're at greater risk for cardiovascular and cerebrovascular events, which can be precipitated by anti-VEGF, so it's worth noting that. Pregnant patients, but of course you can also consider observation until postpartum. And again, and patients that can't travel, that can't come as often, because the DEX implant does allow us to see patients less often. And again, just my last slide here, in a post-hoc analysis of data from the DR-CERNET protocol eye, almost 40% of patients were non-responders or suboptimal responders to anti-VEGF therapy. DEX implants, as well as fluocinolone implants, are effective in treatment-naive and anti-VEGF refractory eyes and eyes with chronic macular edema. The DEX implants appear to be faster than anti-VEGF in resolving hard exudates, and delaying and initiating therapy appears to limit the anti-VEGF response. I showed you a lot of data that on all those clinical trials, the sham control group, who delayed therapy, the response to anti-VEGF drops dramatically. Intravitreal steroids can be considered in diabetic macular edema patients with a recent MI or stroke. The DEX implant-related cataract and IOP elevation can be predictable. I didn't really talk about management of that, but the nice thing why I like the DEX implant over triamcinolone, for example, is the triamcinolone-related intraocular pressure spikes tend to be much more severe and much less predictable. They can happen much later. With the DEX implant, they're quite predictable. They happen 6 to 8 weeks after the DEX implant and tend to be more modest, more moderate, and easier to control. Cataracts happen with steroid use, and again, having a DEX implant on board during cataract surgery or immediately after really does control the diabetic macular edema. And again, importantly, when anti-VEGF therapy is used as first-line therapy, which is essentially all my patients, 3 intravitreal injections of anti-VEGF are enough to give us, in many cases, enough information to make a decision as to whether we want to continue giving anti-VEGF or to switch over. And again, by 6 injections, I've almost always made my decision as to whether I stay with anti-VEGF versus switching to steroids. And again, when I do switch to steroids, it tends to be the DEX implant. Thank you very much for your attention. I'm glad to address any questions.
Fantastic talk. Thank you so much. You know, really covered a lot of ground there, and you've addressed those vision debilitating manifestations that we see all the time in our practices. You know, is the presence of lipid on presentation something that will lower your threshold for going to DEX implant and shorten your course of trial of anti-VEGF in DME patients?
Yeah, that's a great question, Ed. And the answer is yes. What I do, and I didn't really go into it, but what I like to do is get a OCT scan every visit. Not everybody does that because there's data in that. So they come in after the first injection, 4 weeks later typically, and I look to see how much reduction of OCT thickness there's been. And then I bring them back, give another anti-VEGF, typically, again, my usual paradigm, and then bring them back 4 weeks or so later and look again. I try to do that for the first 3 injections. If it's gone a 20% reduction, then another 20% reduction, and then another 20% reduction of excess macular thickness, that trend line is pretty good. It's not yet dry, but it's heading the right direction. I'm more than enthusiastic continuing anti-VEGF at that point. If, however, after the first injection, there's a 20% reduction, and then it flatlines at the second injection, third injection, no further reduction, then I'm not happy. So that's my usual protocol. Then I look carefully at the second set of 3 injections between months 3 and 6. Now back to your question, if there's exudates, I usually still will start with anti-VEGF, but I'd like to see what that first dose does, maybe a second dose. And I'm more prone to switch early, but I still feel comfortable giving the 3 initial injections before making a thoughtful decision. But I'm much more inclined to not, you know, sometimes there's so much gray zone in management of diabetic macular edema when you're thinking about it. Right? I tend to be broadly minded in keeping with anti-VEGF, but when I see exudates, I'm much more likely after those 3 injections, initial injections, to switch to steroid if I'm not seeing the response that I like.
That's great. You've generated several questions. I would ask our audience to submit your questions into the chat or the Q&A. And Dr. Kupperman, if you would be kind enough to review those interactive options and answer some of the questions, and we'll move on with the program. We're going to thank you, and we hope you stay safe and from the tsunami.
Yeah, tsunami alert, amazing. I mean, we get earthquakes here, of course, but tsunami, that's a new thing. So anyway,
yes.
Cheers, everyone. Congratulations on a great meeting.
Thank you. Okay, so we're going to get another opportunity to hear from Dr. Koch. Dr. Koch, as you know, is the professor of ophthalmology at Baylor College of Medicine in Houston. And he's going to dissect for us the various methods used for IOL power calculations and their sources of error, and discuss new approaches in postoperative modification of IOL power in his talk titled IOL Calculations 2022, Progress and Limits. Thank you again, Dr. Koch.
Thanks, Ed. I'll share my screen, and here we go. All right. Well, let's talk about our IOL calculations, and I think you'll hear from Warren as well on Warren Hill on a lot more on the same topic. And these are my relevant disclosures for this particular talk. Well, how good are we at calculating IOL power, really? Most of us, and this is based in large measure on data from Warren Hill and looking at his numbers that from doctors sending him stuff from all over the world. Most of us are lucky if we're within 80% within a half diopter of target. Now, actually, the best data I've seen was the paper that I helped to write with Adi Abalafia in 153 eyes in his center, most with normal axial length. And the best formula was actually, guess what? The Hill RBF3 with 92% of the patients within a half diopter target. And those are really extraordinary data, and they're hard to match. So what are the sources of error in our calculations today? Well, obviously, effective lens position rises to the head of the class, as it always has been. Measuring of the cornea is the other one, anterior and posterior. And then, of course, refraction, because if we don't get an accurate refraction, then we kind of misinterpret our outcomes as well. Axial length isn't on the list because, of course, optical biometry is doing such an extraordinary job in almost all patients in that regard. Well, the classic way to calculate IOL power is the Vergence formula, in which the power of the IOL is selected based on first entering the postoperative and the desired refraction, the axial length, the average K readings, and then each of these formulas has an internal formula for predicting the effective lens position, our old nemesis. And to do these calculations now, we're getting a lot more sophisticated. We not only measure the anterior cornea, its curvature, the axial length, the anterior chamber depth, now the lens thickness, the corneal diameter, sometimes posterior corneal curvature, sometimes corneal thickness plays into it, refraction, age, gender, and ethnicities are also folded into some formulas, which is very interesting. But I think what's important for us to think about these formulas in categories, the ones that are based on that formula I just showed you for geometric optics, and they vary according to the number of variables that are used to calculate the effective lens position, whether it's 2, whether it's 5, or whether it's 7. We have ray tracing, and of course we have access particularly to the Ferko optics in the lens star, in the IOL master. Artificial intelligence, with of course the head of the class here is the RBF3, Warren's formula. But you'll see there's EVO, there's Pearl, and actually there just be kind of a string of proliferations of these artificial intelligence formulas. It's like there's one on every block these days. And then we have combination formulas, the lattice formula, the Kane, the full Monty. And what's interesting to me is that we think we need to remember that all of these formulas use prior data to refine whether it's the prediction of effective lens vision or adjust the axial length. So actually all formulas have an element of big data. Ideally, you would think that ray tracing would be best because it incorporates all aberrations, those of the cornea, those of the IOL, the asphericities of the IOL, both surfaces. But and thinking about the eye and segmented axial lengths might help, and we showed that does actually give a little bit of improvement in accuracy in the Barrett formula. But most of these formulas now kind of take some of that into account. And the limitation of ray tracing is the same problem. It doesn't have a unique solution to predicting the effective lens position. So the outcomes with our ray tracing formulas, at least up to date, are not any better than our other formulas. I think they may be more helpful in eyes with irregular corneas to take into account that irregular topography, but they just haven't really shown the promise we hope for them. So what can we do to improve the prediction of the effective lens position? Well, you can take a big data approach like the Hill formula, which basically ignores the effective lens position and tries to get around it by having this incredible matrix of data from which to select the power. But it's interesting, if there's people have looked at measuring using OCT preoperatively and intraoperatively to estimate the equator of the lens. And these studies have shown improved ELP prediction, but none of them yet have shown superior accuracy in calculating IOL power. And unfortunately, ELP shifts postoperatively, and it's unpredictable. In a study by Hernshaw and Findle showed that in 17.6% of eyes, there is a shift in the anterior chamber depth, the ELP, of a millimeter or more from 1 hour to 2 months. And how many of us have seen the patient come to the office one day post-op 20/20 and thrilled, and come back, at 3 weeks, 20/30 minus 3/4 and furious? So unfortunately, that's the world in which we live. So are we stalemate with the ELP issue? Well, think of it this way. I don't know, not necessarily. Let's say we improve the ELP prediction in 1 of 20 patients at a 90% accuracy rate. If we're really that accurate, if we could reduce that one patient, eliminate that one patient, that's a 50% reduction in patients who are off by a half diopter or more. So, it's still worth pursuing. And with our problem child, as I'll talk about later, short eyes, ELP prediction is still a challenge. Well, what about the cornea? The cornea, of course, is the largest source of error over which we have at least some control because it impacts the accuracy of our calculations, determining what kind of IOL to choose for the patient, and of course affects the postoperative vision if the quality of the corneal surface is not good. Biometers have been a fantastic advance for us because of the LEDs, whether they're 2 rings or 3 rings. By having multiple rows, multiple LEDs, the qualitative and quantitative data from biometers has really taken us a huge step forward. I like topography as well, and I'm a big fan of placido disc topography. I think that the Myers are very helpful to understand what's going on with the cornea. They are the raw data. And for example, you look at a patient like this, well, you see a kind of a blue spot, okay. But if you look at the Myers, blow it up, you can see this area right there. And that's all you need to see. You don't need the color map. You just need to see that in the distortion, and you know that you need to address that. Sorry, I'm losing my voice a little bit here. Likewise, here's a patient with anterior basement membrane dystrophy. You can see all the irregularities, and here's all the stuff going on in that cornea, a cornea that really needs to be treated. And then there are devices, topographers that use multiple LEDs, either tricolored as in the Cassini or with all white as in the iDesign. And I think those are going to kind of be more important going down the road. What about tomography? Well, Scheinflug, of course, either with the Galilei or the Pentacam. And I love my Galilei, I love my Pentacam, and I love my OCT. I don't know that any of them using purely elevation are as accurate for anterior power, although I think we may see a change in that with the Anterion, which is a Heidelberg biometer coming down the road that takes about 300 cuts in the cornea. And I think that may prove to be a very accurate biometer. And of course, it's very helpful to have tomography to rule out ectasia, and because we have to talk to our patients about multifocal IOLs, rule out abnormal topography, and also be able to say to them whether or not we can even enhance them if their cornea is safe enough for that. All right. So if you look at the measurements with our biometers, there's a study that just came out from Oliver Findle's group comparing the IOLmaster 700. And you can see that the repeatability for 95% of the values was really very good for the IOLmaster, LenStar, and anterior. So that means that only 5% of their measurements vary from, basically point on either side of 0.2. Again, though, that is still 5%. But what's interesting also from that study is if you look at, there's excellent reproducibility, but the measurements between some of these devices are not interchangeable. Let's see, I think my slide didn't drop here. Here are Bland-Altman plots comparing the IOLmaster and the LenStar, and this 95% limits of agreement. You can see that that's plus 0.86 to minus 0.73. That's almost a 1.5 diopter range. So there can be a lot of differences between these various devices. Interestingly, the IOLmaster 700 and the Anterion fit more tightly with each other. So, but even then, here we are minus 0.55. So there are differences, and you can't use these devices necessarily interchangeably. And it means you may need different lens constants for different devices, and certainly for toric IOL selection, that's relevant. So, and in my clinic, every pre-op patient Every new patient gets a placido topography, tomography, so I can look at the surface and look at the corneal thickness. We got to be skeptical. Here's a patient who presented for cataract surgery from me. Here are the lens star readings. 4334, 2 diopters of astigmatism. You know, I'm kind of getting geared up for a toric IOL in this patient. Interestingly, the IOL master that day, 700, didn't give me any K readings. And I took a look at the Myers and, oh, I'm missing a point right here, aren't I? There's something that's dropped out. And it's good fixation, so that's not the problem. So that patient had been in my office 3 months previously, and here's the Galilei with very good Myers, so I have a good image. And the K reading is 4460 instead of the 4334 with a lens star. And the astigmatism is 1/10 of a diopter instead of 2 diopters. So if I treated based on the lens star, I would have been so far off. And it's not a criticism of the lens star, it's a criticism of getting one measurement. And here are the lens star images. We looked at them, look at the irregularity right where the dropout was for the IOL Master 700. So we treated the surface. Everything looks good, put an EDOF in this patient, and he got a great result. So you need more than one measurement. You need to verify your data, the raw data. And you can do it visually by looking at the qualities of the reflections of the LEDs, the Myers of the LEDs, or you can use Warren's criteria for range. If you have the acceptable range for corneal power in terms of standard deviation is 0.3 diopters and 3.5 degrees for the steep meridian. And for the 2 weeks prior to IOL calculations, I have every one of my patients, at least I ask them to use preservative for artificial tears, use Warren compresses and lid scrubs. And that's really, I think, improved the quality of my measurements. But even axial length measurement is not infallible. Here's a patient who comes in to be measured, and sorry about the image from the, get that out of my way so I can see it. You can see the difference in axial length here, 2659 as opposed to 2703. So the lens star gives you a warning signal that there's a difference. And the standard deviation of the reading is high, it's 0.127, whereas the criteria we use are minus 0.02. So interestingly, there they are. They're fairly, here are the ranges, they're all in that same sort of range. But the IOL Master 700 said 2693, which is a heck of a lot closer to this 2703. In fact, it got 2703 as well for the right eye. Well, what happened? We repeated the measurement with the lens star and got 2691. And the problem was the technician had started with the optical head too close to the eye and got a false reading. So you can even have an error with something as accurate as optical biometry. And then we have validation criteria, and I'm not going to go over this because Warren has really been the leader in this area, and I'm sure he's going to talk about it. Well, what about short eyes? Short eyes are challenging, and they remain frustrating. And we published a study in which we found that the Holiday 2 is actually best for eyes with axial length of 22 millimeters or less, but still less than 80% within a half diopter. The Barrett was actually a fair amount lower, interestingly, as good as that formula is. And in fact, nearly every study is showing less than 80% within a half diopter target. We do have a new Heal RBF3 and some newer formulas, and we'll see if they really can improve what we get. Here's a patient that came for cataract surgery for me. She was a 3.25 diopter hyperope. Axial length a little short, not too much. Shallow anterior chamber 2.39, but a very thick lens, 5.19. Corneal diameter normal. So the IOL power of 28 diopters was predicted by the Barrett for minus 0.15, Holiday minus 0.02, and the Hill RBF3 minus 0.36. And she ended up minus 2.12. And indeed, the same outcome occurred with a fellow eye. So we took that into account in the calculation for the fellow eye, fortunately. So the reason for the poorer outcome in these short eyes is ELP prediction is challenging. We have a high power IOL, and a very small shift results in a big refractive change. And there's a lot of variable anatomy in these small eyes in terms of the anterior chamber anatomy. So for second eye adjustments in small eyes, you know, we traditionally say, well, if you're off by a diopter in the first eye, you adjust for a half diopter in the second. In these small eyes, I adjust 1 for 1 between if there's a 1 diopter error, I make a 1 diopter compensation in the IOL calculation. And so what about long eyes? Well, we're doing well. Our axial length modification is started the whole conversation about that. And in a data set from Warren Hill, we found we got 93% within a half diopter, but you can also get great results now, obviously with the Hill, the Barrett, the Kane, and the Olsen. So this has really been kind of a problem solved, fortunately, a real area of hope or glimmer of progress for us. And we're doing better because these are low power IOLs. So if you get the axial length right, ELP doesn't have that much impact on it. Well, what about the post LASIK eye? Still a problem. Bottom line, because the 3 main sources of error that we talked about are magnified. Corneal power, ELP, because the formulas that use corneal power to calculate the ELP, corneal measurements, anterior greater variability, posterior, we're still not quite sure we've got the accuracy we want on the posterior cornea, and refraction has soft endpoints. We want to be 90% within a half diopter in these patients. But the best studies that I've seen, there was one small study from Maskett and Nicole Fram that got 85% within a half diopter of target for myopic LASIK. Every other study I've seen is less than 73%. We do like the Barrett and the Maskett formulas. For hyperopic LASIK, again, best data, 73% within a half diopter of target. Our results are poorer, 57%. And measuring the posterior cornea just hasn't given us the benefit we'd hoped for. Our data using the standard Hygus formula with TK, the total keratometry from the Zeiss, we're still less than 70% within a half diopter of target. And the Barrett TrueK, a paper that Barrett co-authored, 72% within a half diopter of target. What about Aura? Well, it does take into account the posterior cornea. Our data actually showed we did worse with Aura, but we do a lot of measuring preoperatively with a lot of devices, including the Avanti OCT. This is a paper presented at the Academy by Nicole Fram from the Alcon Aura database, Analyze Aura US database, 1,000 eyes. And they found that within a half diopter of target, 76% with Aura as opposed to 69% with the Barrett. So there's 76%, 3 out of 4 eyes. Still not 80% and certainly not 90%. And the problem, of course, is that Aura is using its own internal its own IOL calculation formulas to predict ELP, and it's on an altered eye. And the other thing we have to remember in our LASIK patients is you don't want to panic or celebrate on the first day post-op. Post-op LASIK corneas can flatten. Here's a patient, particularly the hyperopes, but also the myopes. Here's a patient after hyperopic LASIK, the target -1.5, post-op day 1, 20/40 J4. A difference map between one day post-op and pre-op shows that there's a lot of flattening in this eye. And the cornea was 25 microns thicker and about 3/4 of a diopter flatter. By post-op week 3, all was well, 20/50 J1 manifest -2, and the topography was back to baseline. The RK, as we know, the RKI takes a long time to heal. Here's a lady, 53, 8 incision RK, 22 diopter toric lens was implanted, targeting -1.5. At week 3, she's +1/4. Month 2, she's -1. And finally, at post-op month 3, she is -3/4. And I really didn't get that right. Here we go. She's -175. So it took 3 months, and she was stable at 5 months for that. So it does take sometimes a long time in the post-RKI. Keratoconus is an even bigger challenge. Our data show that you can have a pretty good fit to a regression line up to about 49, 50 diopters. But you still have to compensate for the fact that these patients it's a hyperopic error, and you have to compensate. But once you get beyond 50 diopters, the regression slope, the R-squared, is very low, and the scatter is huge. We do have new formulas, the Kane and the Barrett, and I think it remains to be seen if they're going to make any headway for us in these really challenging, very steep keratoconic eyes. So the bottom line is we're doing better, but we're approaching a ceiling for accuracy in our IOL calculations. But remember, I'm going to go back to this, that the anterior cornea is usually the cause of suboptimal results in the majority of our patients. And here's a gentleman referred to me after cataract surgery, had a toric IOL implanted, ZCT 400 to correct 2.75 diopters at the corneal plane. The surgeon rotated the IOL at 1 week post-op to correct what was the residual astigmatism. He rotated it to 163. When I saw the patient, here's the patient's refraction, still 1.5 diopters, 20/30 best corrected acuity. Here is the Galilei image, and you can see there's some irregularity here, but here's the money. Here's where the action is. Distorted Myers, this patient had anterior basement membrane dystrophy. I scraped him, did a debridement. 3 months later, here's his refraction. Now he refracts to 20/25. The Myers look good. See this nice bow tie pattern for the astigmatism. And actually, if you look at it, he doesn't have much astigmatism anymore. He's got 1 diopter at 81, as opposed to pre-op with the irregular miles of 1.88 at 44. So I actually, and here they are with the lens star and the IOL master, one diopter at 84. So I just exchanged this patient for a spheric, a non-toric IOL, removing a 19 diopter IOL, got exactly the right target, -150, and did very well. So I think I did mention already earlier, a small aperture optics. We're going to have the IC8 in the United States, which I think shows really some good promise for these really irregular eyes because of the fact it has such a good depth of focus. And look forward to getting that in our hands. And I did mention earlier the Morcher lens, which, as I understand from Mike Snyder's lecture at the Academy, in our practice, just get to it. So far, I've finalized the treatment on 3 eyes and gotten within certainly a half diopter of target in post-LASIK eyes with very happy patients. It is expensive. It's an expensive unit to buy, and it's very labor intensive. And I think we'll see how it fits into our practice flow. And then we have these other technologies still in their infancy, refractive index shaping, using femtosecond lasers to create a lens within a lens, as it were, in order to change power, toricity, and even multifocality. So best practices today: get more than one measurement, verify the quality of your data, educate our patients. This is an imperfect science, and be prepared to have a strategy to manage postoperative refractive errors. Thanks very much.
Thank you for that wonderful talk, Dr. Koch. I do have one question. Actually, it goes back to your earlier talk. It says, would presence of significant higher order aberrations on pentacam preclude using the Vivity IOL?
In my hands, yes, it would, because again, I'm really concerned about quality of vision, and I have been burned in a couple of post-LASIK eyes with a Vivity where there was a fair amount of coma, and those patients got suboptimal quality of vision. So I'm kind of reluctant to jump on board with that. I was hoping it would be something I could use more broadly, but I think we have to be cautious with it. I know others have had good experience in post-LASIK eyes, but I'm kind of I'm pretty hesitant.
Your wisdom and knowledge is greatly appreciated in managing our patients. Next, I'd like to go to Dr. Warren Hill. He's in private practice in Mesa, Arizona, and has received international recognition for his contributions to ophthalmology. He continues a global presence accessible through his websites regarding IOL calculations, and we're very appreciative that he's accepted another invitation to our scientific meeting. He's going to share his pearls with us in his talk titled, "What Went Wrong?" Dr. Hill.
Good morning. Are you able to hear me okay? That works?
Yes, we have that now. We can see your raw slide.
There we go. Okay, how's that?
Perfect.
Do you have
Thank you.
the slide? Okay,
Yes.
great. Well, first of all, we always learn so much from Doug, and I've shared the podium with him many times, and I always come away, knowing a lot more than I did beforehand. What we're going to talk about today is things that can kind of go bump in the night, so to speak. And like Doug and myself and Graham Barrett and others, we often get phone calls and emails from people about things that happened, and it's not exactly clear why. And what I'm going to do is share with you some of those phone calls and some of those emails, and where one small, apparently minor oversight resulted in something unhappy, let's say. So thank you again for the invitation to speak here. And let's take a look here, see if we can get this moving. Okay, these are my industry relationships and none of this. I have no financial interest in the refractive surprise. So let's just start off here with a series of clinical vignettes of some people that had cataract surgery and then ended up having something other than what they wanted. So we'll start off with a lady who's a high axial myope, underwent cataract surgery. And I know the surgeon who did her operation. He's very skilled, very intelligent, works in his own operating room. And the patient was referred to us because her vision was totally blurred after cataract surgery. And again, she's a high myope, so we have a +4 diopter extended range lens for a near plano refractive target being planned for her. So looking at the op note, there was really nothing unusual. It was quick and routine surgery. The operative report states that a +4 lens was implanted, and whoops, +5 +175. That's not what we wanted. And so let's dissect this a little bit and see what happens. And by the way, each one of these cases I'm going to share with you is really representative of phone calls that we all get, and there's contained within each of them are some important lessons. So here's a quick snip from the operative report. You can see it shows a 4 diopter lens was implanted. We got some records from the original surgeon, and they calculated a 4 diopter lens, but things turned out a little different than anticipated. So we did some confirmatory calculations, and using the Holiday formula with the Wang-Koch axial length adjustment, which actually gives fantastic results. Wonderful project by Doug Koch and Lu Wang out of Baylor University. 6 diopters, and we used a Barrett Universal 2 formula and the second version of Hill RBF, and we all got the same thing. So it looks like that would probably be it. But why is this patient so hyperopic? And a 2 diopter error in the lens power at the plane of the capsular bag, really wouldn't be to blame. So we couldn't get any information from either the hospital or the surgeon's office. So we asked the patient, and they got out their card and took a picture with their iPhone. And it turns out that a -4 diopter lens was implanted, not +4, but a -4, which is why this patient came out so hyperopic. So when we do a back calculation just to see where we were, this is using the refractive divergence formula first published by Jack Holliday in 1997. We show that we were off by 10 diopters. So we need 10 more diopters. We had a -4 diopter lens implanted, so the 6 diopters would be the new exchange power, and that's what we calculated using 3 different methods. So the solution to this is have some method in the operating room by which everybody's on the same page. This is from a different patient, but you can see this is a -5 diopter lens, and we have a little square on the paperwork if your surgery center uses paperwork. And we make sure that the sticker from the IOL goes over top of that square, and that square shows the IOL power. And we'll go into this a little bit more in a few minutes. So here's a lady who was referred to me by someone who I consider probably the finest general ophthalmologist in the state of Arizona. When I need cataract surgery, he probably will do mine. And this is an elderly lady who actually has some ocular surface issues, but still wears contact lenses, but refuses to wear glasses. And she wanted to have cataract surgery with the refractive objective being so that she could look at her smartphone without glasses. So she's a little bit of a hyperope. We did a -150 refractive target. Nothing unusual about the surgery. 25 diopter lens was implanted. She ended up minus a half sphere, which I think is a wonderful outcome. She's 20/20 actually uncorrected, and she's disappointed in the extreme, and she let everybody in my office know that. So let's take a look at what happened, and this has some very important lessons for us all. So first we look at the sticker, we confirm that that was the lens that was implanted, and it was. And here's the original calculation, and we did a confirmatory calculation, and this we used Graham-Barrett's formula. And basically, we got the same thing, 25 diopters. So it looks like, you know, we're pretty much on target. We also took a look at the original pre-op biometry, and those of you that use the IOLMaster probably can see immediately what's going on here. We have these little X's, and that's for version 5.4 and earlier. And when you see the little X, it means that the LED reflection is not meeting the standards that are required by the software. So that's our very first red flag. And we have some validation criteria that our office wrote for both the IOLMaster and the LensStar, and their validation criteria for each part of the measurement. And one of the validation criteria is that no X appears in any LED location. And if it does, of course, we either delete and repeat, or we do something else and bring the patient back. So this is when the patient first came in, and my staff did some topography. We noticed a hot spot right in the middle of an axial curvature map. And one of my very bright technicians just put a drop of artificial tears in and had the patient sit with their eyes closed for 30 minutes. You know, you don't want to put in artificial tears and then do the measurements, because you can get some funny results when you do that. So they sat with their eyes closed in a chair in the hallway for 30 minutes, and we repeated the topography, and it looks like this. And so what happened was the cornea was overread by by keratometry. And this is very common as people get older, especially people that may wear contact lenses inappropriately. So what happened? Well, first of all, validation criteria weren't followed. The patient has both a dry eye and as a result, an unstable ocular surface. They're also complicating that by wearing contact lenses. And keratometry overread the central cornea. So the take-home lesson here is that optimization of the ocular surface prior to biometry is becoming increasingly more common. In fact, in our practice, we will not do biometry unless we have the opportunity to optimize the ocular surface. And if a patient says, well, I'm in a hurry, I don't want to do that, then we say, you need to find another doctor. It makes that much of a difference. And as you start optimizing the ocular surface prior to biometry, what you're going to discover is that those multiple flat and steep islands that are seen on an axial curvature map, they basically go away. Aberration profiles can normalize, and the measurement to measurement variation in keratometry may also go away. And Adi Abulafia in Israel first pointed that out in a very nice study. Okay, here's the second case, or no, this is the second case rather. So optimization for 2 weeks prior to biometry, warm compresses twice daily. This is very important because what it does is it helps to mobilize the lipid-rich meibomian gland secretions, which are such an important part in the stabilization of the ocular surface. Of course, lid scrubs to clear away any debris, and then frequent high-quality tears. And we like the TheraTears or the Oasis product. Those seem to work very, very nicely. Okay, so number 3, okay? A low axial myope with a traumatic PSC cataract. These tend to get pretty dense pretty fast, and the cataract is too dense for optical biometry, so an immersion A scan was required. The SRKT formula was used, but there was no Wang-Koch axial length adjustment. A 13 diopter lens was selected with a half diopter refractive target. I think a half diopter for the refractive target is still a very, very good option. Surgery was uneventful, and there was a perfect Capsulorexis, and there's a hyperopic outcome, and with a 20/20 result in stable refraction. So here's what we have. Here's our axial length measurement, 25.77. Patient's a low myope. That's a little bit high as far as the axial length goes, but that's what we got. And this was referred to us by another doctor. And then here's the refractive divergence formula. And here's our pre-op spherical equivalent. And it looks like we're about 6 diopters underpowered at the plane of the capsular bag. So we have a 13 diopter lens implanted. Looks like we need 6 diopters of additional power. And we have, we probably need a 19 diopter lens. So this particular surgeon repeated the optical biometry, and we got a number that was really quite different. 25.77 millimeters was the original immersion A scan, but we have 23 diopters by optical biometry. So the question is, why is there such a large difference between immersion biometry and optical biometry? And so by optical biometry, here's our IOL power calculation, and then a confirmatory calculation using the Barrett Universal 2 formula came up the same. So what happened? And this is very interesting. For those of you who don't do immersion A scans very often, this may send a cold chill up your spine a little bit. So the immersion A scan was carried out in the applanation A scan mode. And interestingly, I had just such a case sent to me earlier this week by another physician. So this does happen. So if you're not familiar with how to use your ultrasound, because we've become so dependent on optical biometry, keep in mind that we need to push the right buttons or select the right software, because we can get hammered if we do a mistake like this. So the axial length error will be the added distance between the probe tip and the cornea. So here's an immersion A scan, and we see the probe tip, we see the double peak of the cornea, the anterior lens capsule, one little internal reflection of the lens, the posterior lens capsule, and then the internal limiting membrane of the retina. So there's our landmarks. And if the applanation A scan is done in the immersion mode, the axial length will be falsely long by this amount. So the displayed anterior chamber depth is also likely to be non-physiologic, and that's the correct axial length. All right, so number 4 here, an extreme axial myope winter visitor from the upper Midwest had cataract surgery several months ago, of course, in another city, and they come down to see us in Arizona to get away from the snow, and has had very blurry vision since surgery, was told to get glasses while in Arizona. Calculation showed that a 12 diopter lens was required for a very low minus refractive target. Looked at the op note, nothing unusual, quick normal surgery. We telephoned the surgeon's office and they confirmed that a 12 diopter lens was implanted, but they didn't have a sticker from either the surgeon or from the surgery center, and we did multiple requests, and patient doesn't have a IOL card. There's the outcome, -8 + 1, my goodness. So that's pretty far off of what was intended. And let's take a look at what happened. So there's the original calculation, 12 diopters. There's a confirmatory calculation using the Barrett Universal 2 formula, and another confirmatory calculation using Hill RBF. They all came up with 12 diopters. So if a 12 diopter lens was implanted, we should have had, pretty good outcome. So everything looks correct. So let's go to the refractive divergence formula. There's our spherical equivalent. There's where we would like to be. And it shows that we're 9 diopters off. So we have 9 diopters too much power at the plane of the capsular bag. So if a 12 diopter lens is required for a quarter diopter, and we have 9 diopters too much power, then it's assumed that a 21 diopter lens was implanted. And here's a clever trick for those of you who are LensStar users that we just happened to stumble upon, and we've used this quite a bit in helping to sort out lens errors. Now, one thing I'm always told is, gee, the lens must be mislabeled. Well, that's pretty rare with today's manufacturing technique and lenses that are manufactured in batches, large batches. The chance of a mislabeled IOL is pretty close to 0 from the large modern companies. So let's take a look at a LensStar measurement in a pseudophakic patient. And what we see is the lens thickness of the IOL that's implanted. And it turns out that for each IOL power, and every model IOL has a unique central thickness. Now, it used to be you could get this information from the manufacturers, but they've kind of stopped doing that. So we have a way to come up with this. So the central thickness of an IOL increases with increasing power. So a 30 diopter lens is going to have a greater sagittal thickness than say a 12 diopter lens. So here's a different patient. There's their pseudophakic lens thickness. And you can see that it's pretty close, 0.65 millimeters. And over the years, we've kind of we've collected data on different lenses. And for a 21 diopter lens, we found that it's around 0.64 to 0.65, depending on how good we are at measuring right in the very center of the lens. So for this particular patient, they had a 21 diopter lens implanted. So let's go back to our patient. So there's our pseudophakic lens thickness, 0.65 millimeters. And the most likely IOL implanted was a 21 diopter lens. And the nice thing about this is that we don't have to take the lens out and send it back to the manufacturer. We can get a pretty good idea. And especially if the lens is off by a large amount, we can say for certain that it wasn't, the lens that was originally thought. So what went wrong? Well, the wrong IOL power was handed to the surgeon. That's what we think. And most likely error was the AFC staff, or the ASC staff rather, transposed digits. So a 12 diopter lens was calculated and a 21 diopter lens was implanted. So let's talk about some ways to prevent this from happening, because this is actually a little more common than you might think. So let's talk about preventing errors in the operating room. First of all, we need to have some kind of list as to who gets what lens. I know some people use software that's accessed and it's put up on the screen, and that's good, but I like to have a list so that I know exactly who's getting what. So here for patient Fuller, who's having surgery at 10 o'clock, it's a 26.5 diopter lens. Behind me is that listing. And here we were evaluating the Holo system from Clarity. Here's another list right there. And then this is George, the OR tech, and next to him is that list as well. And so we do an IOL timeout and everybody says, Mr. Fuller is getting a 21 diopter, say SN60WF, Officer Lurdeck, do you confirm, et cetera. And everybody's in agreement. We also have some paperwork that's pre-printed. And here for this patient, it says the lens power should be 21 diopters. And we've been doing this for a very long time. And the circulating nurse sees that number and also puts the sticker on top, and the two need to coincide. And we also have lemon-colored paper for left eye patients and rose-colored paper for right eye patients. Now, in our area, we had a pretty big error in intraocular lens power, and the over-the-top administrative solution was to have 6 different confirmations from the staff that that's what it was. So here we go, 6 different confirmations that this person that the lens was pulled and it was placed, et cetera, et cetera. I don't think we need to do that. We just need to think a little bit more carefully. So here's another a patient, an extreme axial myope with a moderate cataract who's having, in this case, an elective refractive lens exchange. The Ks are unusually flat here with no history of prior refractive surgery. The SRK formula was used. There was no Wang-Koch axial length adjustment. And a 10 diopter lens was selected with a Plano target spherical equivalent. Surgery was uneventful. 5mm capsulorexis, good capsule overlap. Patient's now -10. Holy cow, -10, and with a stable refraction. So let's take a look at the preoperative measurements. We have a very, very long eye, and we have incredibly flat Ks, and this person had no prior refractive surgery. Now, after surgery, the optical biometry was repeated, and take a look at this. The Ks are now incredibly steep, almost approaching what we see with keratoconus. So here are the preoperative measurements, and here are the postoperative measurements. And what could be the cause for that? And I'll tell you in just a second, and it'll become obvious. So one thing you want to make sure of is for patients with large refractive errors, that if they wear contact lenses prior to biometry, they take the contact lenses out. So the axial length here is greater by the thickness of the contact lens. And the Ks actually are a measurement of the anterior surface. There we go. Okay, so So this is the problem, that the patient didn't have their contact lenses out. Okay, so we ended up -10. We'd like it to be close to plano. And what this tells us is that we have 13 diopters too much power at the plane of the capsular bag. So a 10 diopter lens was implanted. We have 13 diopters too much power, so we need a -3 lens for our exchange. And this refractive divergence formula is a free download from my website. And we did a confirmatory calculation using the Barrett Universal 2 formula and came up with a -3 diopter lens, just as we predicted. So here's number 5. Still on number 5, my mistake. Okay, the patient did not remove her contact lenses prior to biometry, and we need to follow validation criteria. And anybody who has a high refractive error, we want to ask them about, contact lenses. We always tell our patients to take contact lenses out, but sometimes people forget. And in the validation criteria, if the average K power is greater than 48 or less than 40, we confirm that. Okay. Here's somebody I hope never comes into your practice. This is probably one of the most unpleasant people I've ever met, and I'm going to share his story with you. So 66-year-old attorney, high axial myope with some astigmatism, -1650 + 3, desires a toric IOL. The referring doctor said he demanded a toric IOL. And the referring doctor did everything right. He validated the Ks on the lens star, did the Barrett toric calculator, put in a low power SN6 AT7 and targeted plano. Did femtosecond surgery with digital marking, and the same day post-op check, the vision was perfect. But the next day, the vision was absolutely terrible. And this guy was so angry, he refused to see the original surgeon. He only saw him just for the same day check, and brings all his medical records, and I'm including his colonoscopy. It's amazing. So he's -150 + 3, he's 20/20, he hates wearing glasses, he let everybody know that, and demands we fix this right away. And of course, we're happy to, but sometimes people can be a little bit more pleasant, I think. So there's the sticker, no question that that's what he had. And the basic necessary information to help sort this out is a stable manifest refraction, the observed meridian of toric IOL placement, and in this case, it was 139 degrees, and we need to know the IOL implanted. And most of you are familiar with John Berdahl and David Hardin's astigmatismfix.com website, a wonderful tool for ophthalmology. And plugging everything in, what we get is that the ideal meridian of placement is 110 degrees, so we have to rotate it clockwise, and the anticipated manifest refraction after this rotation is going to be plano. Now here's a tool you may not be aware of, and I think this is even more sophisticated. This is the main page of the ASCRS website. This is the Barrett RX formula, and this is just a little bit more sophisticated, and it works very nicely if you're thinking about doing something other than just rotation. Perhaps if you put in a Vivity and they didn't like that and you want to do the Panoptix, if you're going to do a different lens that maybe needs a 3-part solution, which is the spherical power, the toricity, and the meridian of alignment. So the example I'm going to show you is different than this first patient. So basically the Barrett RX formula has, you put in the current manifest refraction, and then the Ks, this helps the calculation for the spherical component, the pre and post-op Ks, the target post-op refraction, and the toric IOL that was implanted. And then you select the IOL to be implanted and put in a centroid value for surgical induced astigmatism. Do the calculation, and what you get is this 3-part solution: the spherical power, the toric IOL model, and the spherical equivalent, the toricity, and the alignment. And there's the solution at the bottom. A very, very elegant way to do this. And again, this is available as a link from the ASCRS website and also the Asia Pacific Association of Cataract and Refractive Surgeons website. Now, a way to prevent this from happening is to put a CTR in patients who are high axial myopes. The conventional CTRs, I didn't find did very much. Bonnie Henderson worked with Morcher and developed this 10C Morcher capsular tension ring. It not only reduces the asymmetry, but may also create a stop for the terminal part of the haptic. This has since been updated, and it's now the Morcher 20C capsular tension ring. And there was an article in the 2021 Journal of Cataract and Refractive Surgery by Zadral and his group showing that it actually did help prevent rotation. Now, this last patient is we say experience is what you get when you don't get what you want. This is actually my patient, and I'm going to show you something very, very interesting. Okay, so patient presents with a history of gradually decreasing vision. The vision is 20/50, 2400 by glare testing, normal pupil function, opalescent cataract, macular OCT is normal. Previous IOP was approaching 30 and had asymmetric optic nerve head cupping with a greater cup in the eye with a higher pressure. 2 months previously had minimal glaucomatous visual field changes, and on a combination drop like Comigan, the pressure was reduced to about 18. And now ready for cataract surgery. Okay, let's go. Let's saddle up and get ready for cataract surgery. Here's his visual field. You know, sometimes we see these temporal changes that are kind of, you know, we really don't know what to do with them, but in the glaucomatous area for the left eye, there were some relative changes in the superior and inferior arcuate areas. And we decided, you know, given his cataract and his vision, it would be good to go. So here's his surgery, and we'll just buzz through this quickly. Pretty much, you know, uneventful, nice, quick surgery, no real issues. Let's go to post-op day number 1, 20/50 uncorrected vision, and pinhole was the same. That's a little bit unusual for our practice. It has a myostat pupil, so it's non-reactive. Quiet eye, IOL looks fine. Patient says, you know, I thought I would see better. And I said, you know what, I thought you would see better. So here's post-op day number 6, 20/50 vision, not much of a spherical equivalent. He says, my vision's getting worse. He has a new afferent defect. What? An afferent defect, that's not right. And a totally quiet eye, reasonable pressure. The optic nerve is unchanged. The OCT is normal. And what are our immediate concerns? Well, of course, we have an afferent defect. He's not, by day number 6, I mean, his vision should be really good. And what should we do next? So what I like to do is I like to do tests that are very sensitive, but not necessarily specific. And one of the tests that I found gives a tremendous utility is the simple visual field. So let's do a visual field test. Yikes, look at that. The guy's splitting the vertical meridian in the left eye. Now he had a retrobulbar block. So my first thought was, you know, did we do something that we shouldn't have with, you know, with a retrobulbar block? So day number 14, we order a test. So we went from the sensitive to the more specific, and we made the diagnosis. And just, I'll give you just a minute to kind of think, you know, what would the diagnosis, what could it possibly be? And here we go. The guy has a meningioma. Okay. So on day 26, a neurosurgeon successfully resected the planum sphenoid alley meningioma, kind of uneventful post-op course. His uncorrected visual acuity rapidly improved and is now 20/20. No longer has an afferent defect. And his visual field is normalized. And what the neurosurgeon explained to me was that the compression of the a portion of the optic nerve coincided with his cataract surgery, and the neurosurgeon mentioned that he wants this guy buying his lottery ticket for him because, you know, so often we see somebody once a year or once every 6 months, and things can progress. And so that was really, really interesting. So what are some philosophic observations from a case like this? And I still think about this one. Sutton's law is, you know, first consider the obvious. You know, Willie Sutton never said, you know, I rob banks because that's where the money is. Occam's razor, you know, look for the fewest possible causes that account for all the findings. But my dad always used to talk about Hickham's dictum. And Hickham's dictum says, rather than a single etiology, patients are allowed to have as many diagnoses as they damn well please. And that was the case for this guy. So lessons, you know, do not approach preoperative testing on autopilot. think about things that we're doing. Optimize the ocular surface prior to biometry. Validate all your measurements, delete and repeat if necessary. And keep informed, update your office technology as required. Remember, you as a cataract surgeon are being judged by your patients and your peers by your refractive outcomes. What better place to put, both your resources and your time than something like that? And if something doesn't make sense, everything comes to a stop. The carpenters say we measure twice and we cut once. This is a wonderful application of that way of thinking. So thank you very much. And I'll turn it back over to the moderators.
Such good advice, so timely. You've made it very clear, and thank you for sharing that with us. It's just so applicable. Thank you. We're now going to return to the CME portion of our program, and I'm very pleased to announce our next speaker, Ann Coleman, MD, PhD, past president of the Academy, president of the AOS, and professor of ophthalmology at UCLA, is our next speaker. And for her introduction, I'm going to turn this over to our Connecticut Society of Eye Physician President, Jim Martone. Dr. Martone.
Thank you, Ed, and thank you for doing such a great job moderating this symposium, and thanks to Deb Osborne for all her hard work in putting it together. It gives me great pleasure to introduce my friend, Ann Coleman, to be a speaker here today. Ann got her MD degree from the Medical College of Virginia, did her ophthalmology residency at the University of Illinois, Chicago, a glaucoma fellowship at the Wilmer Eye Institute, and went on to join UCLA on the glaucoma service, where she also got a PhD in epidemiology. She's presently the Fran and Ray Stark Professor of Ophthalmology at UCLA, and also is a Professor of Epidemiology at the UCLA School of Public Health. As Ed mentioned, she's immediate past president of the AAO, current president of the American Ophthalmological Society, and she's also current director of the Academy's Center for Quality of Eye Care. On a personal note, Ann and I worked together and taught a course at the Academy for several years on critical evaluation of the literature, along with our friend Roy Wilson. And we took that course to Myanmar for a very interesting experience there on glaucoma and epidemiology. Her research has focused on not only the diagnosis and treatment of glaucoma, but the genetic and environmental interaction, but particularly on the societal impact of glaucoma, cataract, and AMD, along with lifestyle limitations. And then today, Ann is going to talk with us about the 21st century threats to glaucoma care because of the epidemic and pandemic environment that we live in, as well as lifestyle factors and glaucoma. Ann, thank you for accepting our invitation, and we look forward to hearing your talks.
Well, thank you, Jim. That was really great to hear from you. And I really appreciate all of the wonderful things that you said. I'm trying to get my talk. There it is. So you can see my first slide. But I really appreciate your inviting me. I'm just sorry I'm not there in person. It's kind of cold here, I understand. Not as cold as it is on the East Coast, where we're at 59 degrees, which is chilly in LA, probably balmy for you guys. But thank you. I have 2 talks, so I'm going to move along quickly for 45 minutes. And the first one I thought I would do with the epidemics, pandemics, and glaucoma care. I don't have any financial disclosures. But recently I had a 12-year-old female with a history of secondary angle closure glaucoma, a past medical history of Kawasaki's disease that was treated with steroids. She did have iris and pupillary cysts. And back in June 2019, because of progressing glaucoma in her right eye, I placed an Ahmed glaucoma valve implant. Now this young lady was last seen July 29th, 2019. During the post-op period, her mother was diagnosed with breast cancer. And with the COVID pandemic, we didn't see her again. for almost 2 years. So she showed up in September 2021 and was still using the medications that we had started back there in July with atropine, alpha-GAN, Cosept, and rocklatan. And at the time in July, her pressures were 13 in the right and 15 in the left, vision 20/40 in the right, 20/30 in the left. Well, unfortunately, when she showed up almost 2 years later, it was 20/50 in the right, vision 21/50 in the left, pressures of 18 in the right and 24 in the left. The child had been complaining a little bit about her left eye to her parents, but because of the pandemic and the mother's chemotherapy and radiation therapy, they just didn't feel safe bringing her in, unfortunately. These are the optic nerve disc photographs, which we do still get at UCLA from 2018. And as you can see, at that time, there was more cupping in the right eye. The left eye, although still with neuroretinal thinning, was healthier than the right eye. This is just showing you the visual field in the left eye. Did have some superior non-specific changes in 2018. But as you can see, when she returned in 2021, we really had lost a lot of vision and the visual field. And so this patient did end up going into having additional treatment with the Ahmed glaucoma valve implant in the left eye. Postoperatively, the pressure decreased to 7. And fortunately, her visual acuity improved to 20/50, and we'll be repeating the field. And I'm hoping that we did get some visual functioning back in this young lady. Because of this, I thought it was important to really try to start addressing what the COVID pandemic did to ophthalmology and also to our patients in glaucoma. Quickly, I'm going to just go over about whether or not the pandemic is here to stay and become endemic, the impact of it on glaucoma care in different research studies, and then strategies to really tackle it. So the pandemic probably is here to stay because we've had some setbacks to some highly effective vaccines. As we know, we have patchy vaccine coverage with disparities in global access, and also quite a bit of vaccine hesitancy in certain regions and areas of the world. In addition, the vaccine may not always block virus transmission. And so although it does help with the severity of the disease, with it not being able to block virus transmission, you can continue to have outbreaks, as has been reported. The Delta variant, which we were first dealing with this summer, is highly transmissible among the unvaccinated. And this is just a slide showing that in a schoolroom, there was an outbreak of 26 cases following exposure to the unvaccinated infected teacher when she took down her mask to read out loud to the students. And those within closer distance, as you can see, were more likely to be infected than the ones in the back rows. In terms of mutations, as we all have heard from the news, that there are a lot of mutations with COVID-19 that increase viral replication and shedding in the upper respiratory tract. In addition, it seems to be very effective at evading immunity. And so this has created an issue with the vaccines that we do have. The Omicron variant, as everybody knows, is peaking in Los Angeles, starting to decline or at least plateau in the New York area, at least. And it is more antigenically distant from the original virus, which makes it even more difficult for the vaccines. It has led to increased breakthrough infections. Fortunately, we're not seeing an increased potential to cause severe death or severe diseases or hospitalizations. In addition, the higher transmission with the Omicron has led to an increase in cases and actually a greater burden on our health system, which we're experiencing in Los Angeles now, and you have been experiencing in New England. The boosters have been found to increase the immune response, Moderna and Pfizer more than Valneva, which is available in the UK. And it has been reported that with the Omicron variant, the COVID pandemic is now becoming endemic, so it's not going away. Another reason why it's here to stay is I always like to point out that they're animal reservoirs. And 40% of the wild deer in North America have been found to have antibodies to the SARS-CoV-2 virus. So with the virus being an animal host, such as wild deer, we have adaptive mutations and then also hybrid viruses via recombination. And so this means that we can constantly have resurgence of the COVID virus because it does have an animal reservoir such as wild deer. Thinking back that we have actually faced this back in 1918 and 1919 with the H1N1 influenza A pandemic or the Spanish flu. The pattern is that there were mild waves of the flu pandemic in the spring and it became more severe in the fall. And one of the things about the flu pandemic back then is the waves occurred outside of the usual influenza season. So when you have a large susceptible population, just as we've seen with COVID, it can occur in seasons that are not usual for flus or other types of colds to occur. The H1N1 influenza pandemic continued to cause epidemics until the 1950s. And it was then replaced by H2N2 influenza A virus, which then helped it disappear. And just to point out, the later seasonal epidemics were actually more virulent than the 1919 H1N1 influenza A pandemic throughout the world. And this is just showing how similar both pandemics are in terms of the masking. We've had people on Twitter masking their pets as they did back there in 1919. Also masking at sporting events as we've also done here with the COVID pandemic. I just wanted to mention the ophthalmologist, Dr. Li Wenliang. I think it's important to mention him because he did die from the COVID pandemic, as did several of our colleagues who are listed on the AAO website. When you think back to the pandemic, at first it was extremely scary because we did have colleagues dying while providing care. And Wenling died after he did alert the WeChat group in China about the new virus and a new flu type symptoms that were very virulent and deadly. So in terms of more specifically glaucoma care, we have been having a lot of different studies done, but just thinking back to March 18th, 2020, the American Academy of Ophthalmology, when I was president, we came out with a policy. And now it might seem routine, the Academy's giving policies, but actually this was kind of new for us. And we came out and recommended that all treatment other than urgent or emergency care was paused because of the risk of the SARS-CoV-2 virus transmission. We also thought it was important to pause because at that time, if you think back to 2020, how we really had a lack of disposable medical supplies and PPE. So we really felt that they should be diverted to the hospitals and the ICUs and emergency rooms where they were most needed. The list of urgent and emergent procedures at the time were procedures for glaucoma, such as trabeculectomy, drainage devices, filtration surgery. However, cataracts were not considered urgent and emergent procedures. The majority of private practitioners did listen. And then when we did an Academy member pulse survey in May 2020, we found with a response rate of about 10% that some of the practices had started to reopen, that they did close during March and April, and then some were coming back up to reopening in May, but about a third of the ophthalmologists who we surveyed in May 2020 were not back in the operating room yet. And so As we all know, time has gone on, and people have started to adapting more into dealing with positivity with COVID-19. However, when you look at the study done by AZ and others using US claim-based analyses, what you see is that comparing pre-COVID-19 in January 2018 to February 2020, and the case rate in COVID-19 during COVID-19, which was March to June 2020, there was a decline of cataract surgeries. The monthly mean declined almost 50% with a relative risk of 0.77. There was also a decline in the laser procedures. As you can see with LPI, that decreased pre-COVID to during the COVID pandemic, as did MIGS procedures and laser trabeculoplasty. Drainage implants and trabeculectomies, however, during the comparison of the number of cases pre-COVID to during COVID did not change at all statistically significantly. So that's showing that individuals did decrease the number of cases that were not emergency or urgent during March to June 2020 of the COVID pandemic. There's also been impact of COVID-19 on missed clinic visits, which is similar to what happened to my patient that I presented. And one of the things that was found is that patients prior to COVID, about 82% of them completed all of their scheduled visits. During COVID, you had only 60% of them completing their scheduled visits. So there was a decrease in patients showing up to their clinic visits. Interestingly, in this study done by Brandt and colleagues, glaucoma had one of the lowest rates of missed clinic visits. So our glaucoma patients tended to show up and keep their visits. In addition, Asians, individuals who are elderly, and those who are defined as having cataracts only were more likely to miss clinic visits during the COVID-19, which was March 16th to May 31st, 2020 in this observational study. So what are the strategies to tackle COVID as related to glaucoma care? Well, one of the studies that was done by Pauli's group at Michigan really was an attempt to leverage big data, and actually is very helpful for those individuals who have electronic medical records. But they did risk stratification, and they found that of 72 patients with scores less than 0, meaning that they had severe glaucoma and few COVID-19 risk factors, the specialists agreed with this algorithm that 76% should not be postponed and that these patients would come in to be evaluated. And of the 1,700 plus with scores more than 25 or equal to 25, which meant they had mild glaucoma and also had severe COVID-19 risk factors, the specialists agreed that about 82% of them could be safely delayed. And this is just showing you the table from their paper where they looked at their algorithm compared to the glaucoma specialists and their comfort, and really showed that the COVID-19 risk scores that they used in terms of pregnant and breastfeeding, age, and also the Charleston Comorbidity Index versus using the type of glaucoma and severity, basically with surgery in the past 3 months, whether the patient was mainly affected in one eye, intraocular pressures that had been recorded in the past, and then also the mean deviation on the visual field. This risk stratification can be done even without an electronic medical record, because you could potentially just look at your paper records if that's what you have. For the environmental disinfection, if you think back to 2020, people were quite concerned about COVID-19 being passed off on packages and also from your items from the grocery store. So I remember wiping down everything I brought in from the grocery store and either leaving my packages outside for 2 to 3 days as recommended, or wiping them down before I brought them into the house. The Academy also came out with guidelines on environmental disinfection. And it's not that we weren't keeping our offices clean before, but this really made it so that they were cleaned even more effectively with diluted household bleach, alcohol solutions of 70% or more, and EPA registered household disinfectants. In addition, visual field analyzers, some colleagues stopped using their visual field machines, and others of us followed the manufacturer recommendations so that we could continue evaluating our patients with visual fields. In terms of a surface transmission, as we all know now, it's really not thought to be the main way the virus spreads. However, it's not been completely ruled out, and so it is recommended to continue environmental disinfection, although the main concern, as we all know, is people and not surfaces. One of the ways that we have been tackling the COVID-19 access to glaucoma care at UCLA and also at other centers is to really bring patients in for in-person data collection and then going to video visits to go over this data collection with the patient, with the physician. This helps mean that the patient is hanging out at our office for 2 to 3 hours, waiting in lines, that they come in, get their visual fields, get a pressure check, and then leave without seeing anybody else. And then we can call with a video visit to go over any concerns. These type of virtual appointments are not helpful for everybody. Some of the patients that are quite severe need more evaluation and also want to have more one-on-one. Also, those patients that are post-operative, we really do want to look into the eye. So we haven't been using this model, but it has sped up the visits for those patients that especially have severe COVID risk factors, feel uncomfortable coming in, and really don't have a need to be seen in person at that time, but do need to be followed up for their glaucoma. Another way of handling it are the drive-through IOP checks, as the Kellogg Eye Center at the University of Michigan reported on. And there they just measured eye pressure with the eye care tonometer. And then the physician either talked to them in real time while they were sitting in their car or did a video visit. And they were actually able to do 241 visits over 14 half-day clinics, with each visit being 5 minutes on average. And they were able to do about 5 to 45 patients per session. So this was a way that they were able to really continue glaucoma care. One of the things I want to point out is that with the use of home monitoring, such as with the visual acuity, optic nerve imaging, and even eye care home and the visual fields, that we have to be aware of disparities, that there is a digital divide, and that this can be by age, it can be by underrepresented minorities, socioeconomic status, region. And so when we're trying to improve access to all of our patients, we want to be quite aware that there are patients that aren't going to be able to really log on to their iPhone app at UCLA and interact with me through our MyChart app. And so I think that's extremely important to offer many ways for patients to access our care. Take-home points, COVID-19 is now endemic, and that we do have studies going on to see if patients that couldn't come in, that needed to come in, did have a progression of their glaucoma in the wake of COVID-19 pandemic, as happened with my young patient. And then we want to look ahead towards recovery and to really continue the safety protocols and the environmental disinfection that started during COVID, to really continue doing that in our practices, and also utilizing the virtual patient visits, and also how we approach interacting with patients with the digital divide in the future. So now going on to the next talk, which is lifestyle and factors, lifestyle factors and glaucoma, and just checking to see that there was a comment in the chat. But I'll go into lifestyle factors and glaucoma. I also have no financial disclosures on this one. And what happens is a lot of times we get patients that say, what can I do to help my glaucoma? You know, and do we tell them to sleep more, eat less, acupuncture, drink coffee, avoid coffee, use blue light filters, smoke weed. So there are a lot of things that our patients in California ask us about, you know, and there are some of these habits that you could call positive, because not only may they have a positive effect on glaucoma, such as exercise, sleep, and caffeine, but also may have positive effects on a person's overall health, or those that may or may not be so helpful, such as marijuana, smoking, and other dietary factors. And so when we look at aerobic exercise and pressure, there was a meta-analysis done that included 10 of 63 studies. And there was an average of about a 4.2 millimeter decrease in pressure after exercise in sedentary individuals, and around 2 to 3 millimercury decrease in pressure in normally active individuals. So as we all know, if you're sedentary and you start exercising, you can get a better effect on your blood pressure and your pulse. Well, that also happens with eye pressure. One of the things they found in this meta-analysis that the intensity and duration did not contribute to the overall effect size, nor did it really explain the difference between those who started out sedentary and were normally active. In terms of looking at glaucoma, in the 2005 and 2006 in Haynes, we looked at the association between exercise intensity and glaucoma. Exercise was assessed by questionnaire, and also the individuals in this in Haynes study actually wore accelerometers. Glaucoma was defined using the Rotterdam criteria for frequency doubling perimetry, and also disc photos, or also using how Wilmer defined glaucoma, just regrading the photographs from the Haynes group. So when we looked at exercise and glaucoma in this population, we found that there was a decreased odds of glaucoma with increased intensity of exercise as measured on the SLR monitor. So, and this was found with both definitions of glaucoma. So this shows this is a pretty robust finding that, you know, you get a slight decrease in the odds of glaucoma, 3% per 10 count increase in the use of the accelerometer. Now, there was a possible decreased odds of glaucoma with more minutes of moderate to vigorous activity. This was found with the Wilmer definition. That's the one based mainly on the images of the optic nerves. But this was not statistically significant, but close. And then with the Rotterdam, where we included the frequency doubling perimetry, there was a decreased likelihood of glaucoma if you did more standing and walking versus sitting all the time. When you look at glaucoma with sleep, there have been a lot of studies about sleep. You know, we have circadian variations with pressure, ocular perfusion pressure, cerebrospinal fluid pressure, and then also some work with melatonin. There's also been studies looking at sleep disorders with sleep apnea and also mood disorders and glaucoma. I just am going to highlight the sleep disorders and glaucoma. And the main one is that with sleep apnea, and there was a meta-analysis showing that sleep apnea was associated with an increased glaucoma risk. And in this meta-analysis, this was more than twofold, 2.46. One of the reasons is with sleep apnea, you know, you get the hypoxia, you get decreased perfusion, and you get increased sympathetic tone. And one of the issues, though, with this study is sleep apnea also affects mood disorders. So you may have some confounding with mood disorders. And one of the studies I did with Roy Wilson was on depression, and we found that glaucoma patients were more depressed. So this could be an issue when you look at sleep apnea, because sleep apnea also is associated with more depression. Now, marijuana and glaucoma. Marijuana is legal in some states. And so the first study on marijuana before it was legal, I like to point out, was done at UCLA. And that was done by Bob Hepler, who was on our faculty as a neuro-ophthalmologist. And they took a group of youthful subjects before they measured their pressure 1 hour before they smoked marijuana. And then they measured their eye pressure 1 hour after they smoked marijuana. And as you can see, there were 11 of these youthful subjects that did this back in 1971. And they found that there was a large decrease in the pressure in about 80% of these 11 youthful subjects 1 hour after smoking marijuana. But one thing that's not pointed out a lot is about 20% of them had no effect on their eye pressure from smoking marijuana. And none of these youthful subjects had glaucoma. This is, however, the study that's been used a lot to recommend the use of marijuana in glaucoma, because as you all know, we really weren't allowed to study marijuana and glaucoma. So one of the things is it's unclear the mechanism of lowering pressure. We do have cannabinoid receptors in multiple parts of the human eye. And so there might be an influence on aqueous outflow dynamics. One of the issues, as was seen even with the study done at UCLA on those 11 subjects, is that there is a short duration of action. Maybe it lasts for 3 to 4 hours. One of the issues are the side effects. The study was done on smoking. And so whether or not you have the same effect when you eat the chocolate bars, for example, that have marijuana, hard to know. In addition, there was time when they were working on the eye drops. However, those were unsuccessful. And so they still have not been formulated in sufficient concentrations. So does the American Academy endorse the use of marijuana as a treatment for glaucoma? And that would be no. And actually, the American Academy of Ophthalmology does have a very good information sheet about this. I think it can be helpful when talking with your patients, because especially in California, this seems to be a popular alternative treatment method that people would rather eat marijuana in their chocolate bars than take their eye drops. So what about cigarette smoking and glaucoma? Well, cigarette smoking has many potential detrimental effects to the eye, such as vasoconstriction and vasospasm. They also, with cigarette smoking, you can have the generation of free radicals and increased oxidative stress. And on the opposite side, you can have a possible neuroprotective effect of nicotine. There's the nitric oxide liberation from the neurons and also vasodilation. So one of the fascinating things about cigarette smoking is that it can be confusing what we find in the studies when we look at cigarette smoking and eye pressure. Roy Wilson did one of the first, if not the first, case control study looking at cigarette smoking and glaucoma and did not find it as risk factor. When we looked at cigarette smoking and eye pressure in that same population I mentioned, the National Health and Nutrition Examination Survey, this time we looked at 2005 to 2008. We had 3,864 participants with about 5.5% with glaucoma. And we found that current smokers had a lower odds of glaucoma compared to non-smokers. And actually, it kind of looked like smoking was protective almost, but this is an association study, but the odds ratio was 0.61. So you had like a 39% decrease in the odds of having glaucoma. And we also saw when we looked at ex-smokers that they also had a decreased odds of having glaucoma overall. However, when we looked at a subgroup, which were the smokers, and those with a greater pack per day of smoking history, they did have a higher odds of glaucoma by about 70%. So as you can see, the effect of cigarette smoking is somewhat confusing because it seems that it is protective, and it's also not protective and associated with glaucoma. So it needs further study. When you think about caffeine and glaucoma, we've heard a lot of studies about coffee being associated with glaucoma. One thing to realize is that in the studies, coffee and tea have very different polyphenol profiles. Coffee increases homocysteine, which does affect soot exfoliation. It also can cause increased aqueous production, which can lead to an increased eye pressure, but it can prevent hypoxia-induced retinal degeneration. Teas have flavonoids, and those have been found to be neuroprotective. So in a study we did in the same population in Haynes, this time 1,678, we looked at caffeinated and decaffeinated coffee, iced tea, hot tea, and soft drinks, defined glaucoma by the Rotterdam criteria, which was using the frequency doubling perimetry and the imaging of the optic nerves. And we found that hot tea consumption was associated with a decreased odds of glaucoma. And this was a pretty substantial decrease. You know, you're looking at what, a 74% decreased odds of glaucoma if you consume hot tea in this survey. Now, one of the things I think it's important to pull out is that in these studies I've been presenting, as you notice, they're all associations. I'm not saying causation. I say that it might be. The reason why is it's really hard to study lifestyle factors. A good example is cigarette smoking. One of the reasons why with cigarette smoking, they had to use a lot of reasons why cigarette smoking causes lung cancer is because you cannot randomize people to lifestyle factors. It's very different and difficult because it's something we choose. And so doing lifestyle factor studies, you know, it's hard to randomize someone to smoking and non-smoking, hard to randomize them to exercise and non-exercise for a long term. We do it for short-term trials, and so those can provide more information, but it can be that maybe it's exercise when you were a teenager that's more impactful than in middle age. And so these issues all can create biases and difficulties, so you need to be quite aware that it is difficult to do randomized controlled trials on lifestyle factors. The studies I've been presenting, the majority of them are associations, so they're not causal studies, but they do provide plausible scientific mechanisms that might underlie potential relationships and provide good areas for further research. So I also wanted to acknowledge my co-authors and those other individuals who have really helped with these association studies that we've been doing. And that gives us maybe 10 minutes for questions. I didn't know if there were any in the chat. The first one in the chat was from Dr. Brandon. And he was doing it with the outdoor eye care tonometry in April 2020. And it turned out they were doing it with temperatures in the 40s, which is outside the recommended temperature range for the instrument to function properly. And the pressures were okay when retested indoors with the eye care. So that's very interesting. Not something that we would necessarily have happen in California.
Ian, it's Jim Martone. Great talks, really enjoyed them. The things that I was interesting between caffeine, maybe related to soot exfoliation, and hot tea maybe being protective. That was an interesting contrast.
Yeah, well, that's why I wanted to point out the different protective components of coffee and tea. You know, a lot of times people think it's just the caffeine, but it could be something different. And that's one of the reasons why diet is so hard to study. And supplements don't always work because we take them out of their natural whole foods, which actually it might be the interaction of other components in the whole food versus just the supplement itself. But in California, we're big supplement takers. So.
Sure.
We're also experiencing in our, as we try to address the COVID pandemic/endemic, lots of our employees are not available for work. How is your facility handling this? How are you addressing still getting the work done as the patients are still now showing up, but we don't have the staff to deal with them?
Yeah, it's a real problem. You know, they did decrease the amount of time that patients, that the healthcare workers can be gone. It's only 5 days now. So UCLA is now doing 5 days to get the staff back and having them wear N95s. I think that one of the issues is that we have had to cut back on the clinics because we don't want patients hanging around a long time. And so that makes it challenging. We have had managers who do have ophthalmic technician skills having to step in to help. I think the hospital has been hurt more than the outpatient clinics with their nurses. But with our surgery, we now have issues with surgery times. We're not allowed to schedule any non-urgent or emergency cases, just like what happened back in March and April. So, and at least at UCLA, all cataracts that aren't emergent or urgent are taken off because they don't have enough OR staff. We also don't have enough technicians to clean the instruments. You know, it's as you know, it's a lot more than just the doctors and the nurses that help an operating room or a practice run. And so we're having to postpone care.
Have you found that the patient time in clinic has decreased? And if so, how are you going to handle that when they expect those shorter visit times in the future as we hopefully get further away from the pandemic?
You know, my patients, it hasn't decreased. That's why we're trying to do more virtual videos. It's increased. It's like the cleaning of the rooms just takes forever, you know, and they're cleaning everything. And so so a lot of people's volume has gotten back to the pre-pandemic level. Mine hasn't. And, you know, and I don't think Caprioli's has. I think that the extra steps have just slowed it down. And I don't think my patients are spending less time hanging out in lines. I try to encourage them that why don't you come for your field this day? And then I can see you another day and I'll be faster. They just won't do it. And I think it's because the distances they travel, that it's like, look, I'd rather spend 2-3 hours in your clinic doing all my testing at once than 2 to 3 hours on each day driving to your clinic. And so it's an issue. Maybe it's better in Connecticut. Y'all don't have the distances.
Well, and we have some people in our community, some physicians in our community that have had to shut down their offices. Somebody in the staff had shown up, tested positive, and they just shut down. It's really obviously altered the flow and their ability to deliver healthcare to the patients. But you know, these are challenges, and that's something I really appreciate about your talk is that you've addressed some of the challenges that you've experienced. We've all experienced them at some level, and we're all kind of fighting them in our own little ways. And it's good to get some anchoring of knowledge in your experience at how it applies to ours. So thank you, Dr. Coleman, for addressing these pandemic challenges, as well as these lifestyle factors influencing glaucoma. Let's see, are there any other questions here?
I see one by David Emmel.
Yeah.
about have I or anyone else done studies to explore the effects of self-medication of glaucoma with marijuana interfering with the use of prescribed medications? And I think that's a great question, and I don't know of any. I think that's probably a good study.
And just one point on that, I have a patient who, this woman is a researcher, so she likes to, dabble with things. She swears, I've only seen her once since she started this, but she swears that oral CBD has lowered her intraocular pressure. And, she came in with a lower pressure, so I don't know. But have you had any experience with oral CBD?
I have patients taking it, but I haven't looked at it systemically. But my patients take bilberry, they go and get acupuncture. They're doing a lot of alternative therapies in addition to taking the medications. And so, but I haven't studied whether they have any interactions with it. But yeah, I think that it's hard to know because I don't have everybody also admit that they're taking oral CBD, even though it's legal now in California.
And David just put in that one study shows that it raises IOP. So there you go. I don't know,
Yeah, it's kind of hard to know because there's so many other factors. I mean, because I don't know that much about oral CBD, but whether it increases the appetite, because then that could increase the BMI, which could then increase the pressure. So it's like, there are lots of unknowns. And then
there's one about drops too.
Yeah, I think someone mentioned that the drops work to lower pressure, Dr. Kagan said, but the eyes always got red. But then maybe they should bring them back because now Rocklatan and Repressa, the patients are getting used to really red eyes. So, that might not be the problem it was 20 years ago.
Any other questions from the audience? All right. Well, thank you again, Dr. Coleman, for spending your Saturday with us. We hope that you'll join us again in the future sometime.
Well, thank you for inviting me. Thanks.
Thank you, Ann.
Our pleasure. Our next speaker is Natalie Afshari. Dr. Afshari is a professor of ophthalmology at UC San Diego and serves as chief of cornea and refractive surgery there. Today, she's going to discuss recent advances in endothelial keratoplasty and update us on recent scientific advancements in selected corneal diagnoses in her talk titled Advances in Corneal Transplantation Surgery and Fuchs Dystrophy. Welcome, Dr. Afshari.
Thank you so much for your kind invitation to be here today. Hope that you can hear my voice. And Dr. Lim, please let me know some of the videos have sound if they do not come through. It's a pleasure to be amongst colleagues in Connecticut and New York State. I just wish I was there in person, and great to hear from some of the other colleagues around the country. I'll be talking about some of the advances in corneal transplantation surgery with a focus on endothelial keratoplasty, Fuchs dystrophy, and the works that we have been doing. And these are my financial disclosures. What is relevant is the NIH grant, as well as a patent that we have on conversion of stem cells to corneal endothelial cells. So let's first talk about a few advances in the field of cornea and refractive surgery in the past couple of decades. And there have been a lot, including refractive surgery. We have been flapping and zapping the cornea and lasering. We have been even putting rings within the cornea for flattening. We have been doing light therapy to the cornea with collagen cross-linking to strengthen the cornea like the ladder rungs of the ladder. And we all, of course, cross-link as we grow up and we become stiffer. But we have learned a lot more about dry eyes in the last couple of decades, and the whole slew of different therapies that are now available. But still, we have ways to learn more. We have learned more about blocked meibomian glands, something that we weren't paying attention much before. We have learned about downstream cycle of inflammation and the meibomian gland disease, and we have been even massaging the the meibomian glands and paying attention to the tear film. In fact, how relevant with the COVID pandemic that Ann Coleman just talked about and the mask-associated dry eye that we see. We did a study in healthcare workers on a paper that we just actually presented at the Academy, and the publication will come out. But many of the markers of the dry eyes, by the end of the day, when we looked at the tear film osmolarity and tear breakup time and corneal fluorescein and Schirmer, several things that changes as we wear this mask, especially as healthcare workers, from early in the morning until end of the day. And we looked at 50 ophthalmic workers, including all of us. Okay, but speaking of virus, we have had much more understanding of herpes simplex virus within the last couple of decades. There is also works on vaccinations for this virus. By the way, this is an image that one of my colleagues sent to me. And in fact, I was going to use this image as the cover of my cornea book with Dr. Copeland. However, we thought, well, we don't want to use HSV as the cover. We would want a clear cornea. And the story is that the colleague who sent me this image, he was an infectious disease colleague, and he called me and he said, hey, over the phone, Natalie, I have herpes simplex. And over the phone, I said, well, how do you know you have herpes simplex? And he said, well, I have red eyes. And I said, well, a lot of people have red eyes, many reasons to have red eyes. And he said, oh no, Natalie, I did PCR on my own yesterday on my eyes. So here it is. Then he sent this beautiful image once he was seen in ophthalmology. And it was in fact HSV based on his own PCR. So infectious disease colleagues who know so much these days. I want to show you a video about HSV, and it's somewhat relevant to what's going on now as well. And this one has sound, so let me know, Dr. Lim, if you do not hear it.
The average person touches their face 3 to 5 times every waking minute. In between, we're touching doorknobs, water fountains, and each other.
So we have a virus with no treatment protocol and no vaccine at this time.
The truth is being kept from the world.
Cook your samples, destroy everything.
Watch this. It's transmission, so we just need to know which direction.
On day 1, there were 2 people, and then 4, and then 16. In 3 months, it's 1 billion. That's where we're headed.
Okay, in fact, as we have studied the COVID virus, and many colleagues have studied this too, that there are the receptors in the cornea, the TEM2 receptors. Fortunately, it hasn't been at all the primary site or an important site of transfection. But really, what we have had the most advances in the field of cornea has been in the corneal transplantation, and most specifically the lamellar keratoplasty. From penetrating keratoplasty that we had, then the deep anterior lamellar, the posterior lamellar keratoplasty, followed by the endothelial keratoplasty in different versions of it. And I'll be talking about endothelial keratoplasty, Fuchs dystrophy for a minute, surgical interventions, and then genetics of Fuchs, as well as the stem cell regeneration with a focus on endothelium. So first, Fuchs, and this is a patient who has had Fuchs, and one eye has had the cornea transplant and the other eye has not. And you could see the difference and what the patients described with that glare and halos and blurriness and light sensitivity. And this is at the train station in New York. And I think a lot of the colleagues here recognize it. But folks, the common corneal disorder with late age of onset with bilateral corneal endothelial dysfunction leading to corneal edema, because the endothelial cells are those metabolically active cells and have those leaky barriers between anterior chamber and stroma, but they do not proliferate in vivo, and once we lose them, we lose them. When we looked at a 30-year study of Fuchs, 30-year study of corneal transplantation, we found Fuchs to be one of the leading indication for penetrating keratoplasty, no matter what decade we were looking at in US, one of the top 3 leading indications. At the time of corneal transplantation, these patients have quite a thick corneal pachymetry. Mean was about 670 microns. So really thick when we looked at 30 years of Fuchs. And at the time of corneal transplantation, 50% of them have a visual acuity of 20/50 to 2100, so quite affected. First, in terms of endothelial keratoplasty, was posterior lamellar keratoplasty, and then the very common DSEC surgery, and I'll show this with one of my patients. I've just done the cataract surgery, marking the cornea. What we do, we remove the Descemet's membrane. This is an irrigating Gorovoid that I'm using to remove Descemet's membrane. It both serves as an anterior chamber maintainer because it's irrigating, and also stripping like a Sinski, so double effect, but it is a little softer and gentler on the cornea. So removing the Descemet's membrane, sometimes we put trypan blue just to see if there is any more Descemet's membrane left, and then putting the new graft in. There are multiple ways of putting it in, from injectors to non-touching forceps, different versions. But putting it in, and then just like a taco, unfolding it, and then putting the one suture or no sutures, and that would be it, with some air bubble. And then soon after, the patient would be able to see. Although with DSEC, longer visual recovery time compared to DMEC. And here you can see the S, which helps us to know that the graft is right side up as opposed to the Z, and this is a LASIK roller that is centering the graft. Now, at the interface, these patients, here it is the DSEC graft versus the recipient cornea. You can see some pigments, and we have looked at all of this histopathologically, and we found that these pigments, or even we have looked at the residual Descemet's membrane at the interface, and they do not, they're not visually significant, which is very interesting, and interesting that these patients don't develop some haze or interface scarring, even though there are these 2 different pieces of cornea that are touching each other. Now, DMEC came into the play and as the next step, and here it is, preparing the graft, just Descemet's membrane and endothelium, and touching it, putting it in an injector, very thin, very cellophane-like, making it rolled, putting it in injector, and different injectors are available, and inserting it in, gently and slowly. By the way, this patient did have a glaucoma trap, so I'm sitting temporarily, but the glaucoma trap, you can see it right there. And then following that, putting a suture in, and then more of a tapping and opening the graft. It's more a moment of triumph when these grafts are open, because we never know how each of these tissues are truly going to act and react at the time of the opening. And then follow this by air that we would put within the anterior chamber, and I'll show that in a minute. So this is one of my patients who had glaucoma trap. Here is the air, and finally the attachment, and we'll have these patients flap for a couple of days. Now, DMEC is more of a dance, as I was mentioning, and that the graft tumbles and opens, and there is a moment of triumph. So I want to show this video to you for fun how we feel when it's opened. Removing the Descemet's membrane. So this was another patient with glaucoma also that I did the DMEC. Now, often the patients who have glaucoma, we do prefer to do a little thicker grafts such as DSEC. Despite all of the merits, endothelial keratoplasty have their own complications. Here it is. You can see the separation of the graft from the recipient cornea. And this is a detached DSEC, mother of all of the detachments. This was one of the images we actually put in iNet as one of those images to guess what it is. It's truly detached all over, all the way in the vitreous cavity. This was actually one of my patients who, after I injected the air, the endothelial keratoplasty graft disappeared, looking all over the area, the draping, couldn't find it, and then finally looking within the vitreous cavity, and here it was, the graft is floating and floating and floating. And of course, this was a few years back. At the time, I hadn't had any, or I didn't know anybody who had what you call drop DSEC. So we went around the country and asked a bunch of colleagues if they have had any drop DSEC. And there were a number of brave souls who came forward. We collected 8 cases. 5 of them had sutured PCIOL, 2 were aphakic, all required repeat grafts. 6 out of 8 required pars plana vitrectomy, and their vision was anything from 20/30 to light perception, because it depended on when the graft was actually taken out. Cornea is not meant to be sitting on macula, and some of them had PVR when they were left a long time. Interestingly, my patient actually had a PCIOL, but had a large YAG opening, and at the time of injection of the air, instead of it kind of attaching, it went back and posterior and all the way to the vitreous cavity. Now, there are a lot more of these cases that are noted over time. A lot of colleagues actually come forward and tell me, hey, are you still writing that paper? Because they have noticed another case. What else? One of the things that we see is those triple endothelial keratoplasty, whether that's DSEC or DMEC. With DMEC, we have less of hyperopic shift, but with DSEC, we do have quite a bit of hyperopic shift that these patients have. And I thought for a minute to talk about this, especially after Warren Hill and Doug Koch talked about IOL calculations. In these patients, we have hyperopic shift, we want to aim for refractive neutrality. Currently, the aims are anything from -1 to -1.25. So, but we are changing the power of the cornea, and we wanted to come up with a formula to truly calculate how much shift do we have in these patients that we are doing DSEC surgery with cataract surgery. So we'll have more of neutrality rather than guessing that we should be aiming for -1 or -150. We know that the power of the cornea, power of the eye is the power of the cornea and the power of the lens, and the power of the cornea is dependent on the anterior curvature of the cornea as well as the posterior curvature of cornea. And we know that in DSEC, we are changing the posterior curvature of the cornea. And if we assume just half of the upper half of these curvatures, and we go through SAG equation and a number of calculation, at the end, we had the new calculation for posterior curvature of the cornea. So, and actually we published this in IOVS a few years back, and we thought that everybody is going to use this. However, the formula was so complex that, that it didn't catch on, and we thought we need to have a smartphone app, and I'll show you these, the transplant thickness that we have here, we had very good correlation with central to peripheral ratio. And when we applied our model, the average mean refractive shift of these patients was about 0.89 diopter, but our predictability was 98%, and predictability in the mean eye power change was 93% accurate. So finally, we developed a calculator with cornea, with DSEC, plugging and chugging in patients' numbers and curvature. And at the end, it would give us the exact number solution, which here it is. The refractive change is hyperopic to the tune of 0.75 in this case. Of course, nothing is accurate in corneal transplant to that degree, to the second significant figure, but it is helpful. This calculator is available. However, we couldn't put it as an Apple product app, and the reason was University of California and licensing and the Apple and the restrictions, but we have it available. Maybe we can put it on the ASCRS website. Okay, there are many special cases of endothelial keratoplasty. Some of them are post-glaucoma surgery, which I mentioned as we inject air, that the glaucoma trap, or sometimes even two, but the trap, the air can be escaping or can be going to that area. This was a patient, DSEC post-glaucoma tube. The patient's visual acuity was hand motion. And my colleague at the time, when I was at Duke University, Leon Herndon said, "Hey, Natalie, can you do this, this DSEC for this patient?" And the patient was only hand motion. And I thought, what's the point? However, surprised that the patient actually ended up with 20/20, had two glaucoma tubes, and you could see here and here. So at the time we wrote a paper on DSEC with double glaucoma tubes, and we really didn't know what would be the impact on thickness of the cornea changes, but we learned that over time that is not as much of a factor. And then later the DSEC with 3 glaucoma tubes, and this patient you can see had a lot of glaucoma tubes. Some of them were longer. I had a lot of glaucoma colleagues at Duke, so we had many glaucoma tubes, and it was very common to have very advanced glaucoma there. You can see it here. And finally, a patient DSEC with 4 glaucoma tubes. And let me show you how the patient looked in this case report that we published. Real estate was very tough and tight, just like New York City, not as large as Connecticut. So therefore, we did put a very small graft here. So after that, I wanted to know what is the effect of prior incisional glaucoma surgery on graft failure and dislocation and DSEC. And other colleagues have looked at these also, DSEC in patients with prior incisional glaucoma surgery. This is our result. Our colleagues at UCLA have published on this, and our colleagues around the country, other places, have also published on their experience. So we had about 320 patients with just regular Fuchs surgery, DSEC surgery, and about 100 of them, or 96, that had glaucoma. Their demographics was similar, but the dislocation rate was very different. Where the dislocation rate for our control patients who had just pure Fuchs was 2.7% of the grafts. As soon as they had diagnosis of glaucoma or prior surgery or multi-tube, the percentage of dislocation went way higher, with the odds ratio of prior surgery of 7 and multi-tube with the odds ratio of 15. How about failure rates? The same. Failure rates, as soon as we had glaucoma with DSEC, the rates went much higher. As soon as we had prior surgery, the rates went higher over time, compared to 3%, which was DSEC in patients who had just Fuchs dystrophy. DSEC with ACIOL, another possibility. We don't always want to change our IOL, given that some of these patients can have IOP issues and also macular edema. This was one of my patients who actually asked us to write a letter to Vatican. The story is that we did his endothelial keratoplasty despite the fact that he had his ACIOL. And he did well, but then on day one, he was detached. After week one, he was detached. And we said, well, maybe we should consider changing the lens or doing other procedures. And then when he came back at 1 month, his graft was attached. He had his entire church praying for him, and he wanted his priest to be promoted to saint. My fellow at the time was a Catholic who wrote a letter to Vatican. And of course, there was requirement for more paperwork. So what about the second ACIOL? We looked at 31 eyes, graft dislocation was 13%, average endothelial cell loss was 48% at 14 months. So a lot of endothelial cell loss for these patients, right? So you would think that maybe we should do something else, although these patients with corneal transplant of full thickness have their own challenges as well. Here is a patient of mine that I did DSEC, has also ACIOL and has glaucoma tube. Pediatric DSEC is a possibility. This was the very first reported case of pediatric DSEC. My patient was a few years old. Pre-DSEC had a very cloudy cornea, had multiple ocular surgery. And here you can see my patient after I did this DSEC. And after that, I did surgery on his father and his grandfather, as well as endothelial keratoplasty, post-penetrating keratoplasty. And in this case, you can't even see where is the EK, but it clears the cornea so nicely. So endothelial injury in endothelial keratoplasty, very common. Why? Because corneal endothelial cells are extremely fragile. And we try to protect them, but still they do shatter. Comes along endothelial keratoplasty, and we have all of these graft preparation and graft insertion and graft, all of these different steps. So first we wanted to decrease the rate of endothelial cell loss, and this was, we didn't have any non-insertion forceps or non-touching forceps at the time. So we thought, well, perhaps we could put the grafts through IOL cartridge and insert them in the eye. And that actually worked to decrease the graft injury from 26%, as you could see here, and you could see where the graft is actually touching all of the forceps, to the cartridge, which decreased the endothelial cell loss to 9%. The same was with air bubble. That air bubble that we put in these grafts to protect the attachment and to enhance the attachment leads to decreased endothelial cell loss. But showing you this, we made an air bubble model, and looking at the graphs, we had about 15% graft endothelial cell loss just from putting the air bubble in. Yet, despite all of these, our grafts do well. All of these touching and chugging and all of that, still these patients often are having very, very good vision. So we need to rethink this whole idea of damage of endothelial cells and the magic number concept that sometimes we think, how many cells do we truly need? Now, we talked a little bit about Fuchs, a little bit about surgical intervention, but what else could we do? Really, can we regenerate the endothelial cells? And therefore, we wouldn't need any of this, because most of our corneal transplantation is for endothelial disease. Yes, we do have the anterior segment or anterior corneal disease, but that's less of the number of transplant. So let's go ahead and talk a little bit about genetics and the stem cell regeneration. First, we'll start from genetics of Fuchs. It's a late onset disease. It's a disease that affects the endothelium. Few parents are affected, and it's still kind of unknown mode of inheritance, and there's gender imbalance. This is one of my families with Fuchs dystrophy. There are 36 family members that are affected. 36 family members, and I do go to their family reunions, and I do have a voting right in their family to decide if the family reunion is going to be every year or every other year. And I thought this would be the family that we would find the Fuchs gene, but actually it has been quite complex. There were several genes that were implicated in Fuchs, starting with collagen 8A2. It's one of the factors that's present in Descemet's membrane. Then it was SLC4A11, which was noted in some of the Chinese descent Fuchs patients. Then it was TCF4, TCF8, and none of these was really in every Fuchs patient. It was until Keith Barrett and his colleagues had this landmark paper out of Mayo Clinic in New England Journal looking at TCF4, transcription factor 4, in Fuchs corneal dystrophy. So basically, they did a great genome-wide association study, and they found TCF4 to be implicated. Since then, many groups, including our group, have found TCF4 to be one of the largely important causes of Fuchs endothelial dystrophy. In fact, it is a trinucleate repeat within TCF4. It is that these patients have 50 copies or more of CTG repeats within their endothelium, within their DNA, that's leading to disease of Fuchs. We developed a consortium with our team, Case Western Reserve University and Johns Hopkins, and looked at over 2,000 DNA samples of patients who have Fuchs and 3,300 controls. And let me show you this. And this was the paper we published in Nature Genetics, that basically we found 3 novel loci for causes and genes that cause Fuchs dystrophy. So those were important in different things, such as transportation, such as cell membrane, CANK4, ATP1B1, and LAMC. They had essential roles in sustaining and maintaining the health of corneal endothelium. Some of them had something to do with sodium-potassium plasma membrane pump, and that made sense. So now, we can look at a patient, we can predict the risk of an individual developing Fuchs dystrophy with an accuracy of 78%. Looking at endothelial cells of these patients, this is normal. This is a Fuchs patient, and you could see immunohistochemistry. You could see the transcription factor 4 staining to the right, and further staining with the different genetic loci that we found. What about male versus female? We said that females are more susceptible to this disease. Now we can detect differential gender specificity of LAMC1 with greater risk in females and TCF4 with greater risk in males. Okay, so all of that is great. So we have some genetic susceptibility and we understand that. But now what are we going to do to fix it? So we are at the era of stem cell regeneration, and corneal endothelial cells do not regenerate. So can we, with stem cells, regenerate these corneal cells? We know that induced pluripotential stem cells can now be generated from humans. It was Yamanaka who got Nobel Prize in 2012 and found that transferring 4 genes results in induced pluripotential stem cells. So that is, we can from any cell change 4 cells, 4 genes, and have a pluripotential stem cells. And from that stem cells, we can build other tissues. So our goal was from stem cells to go to the corneal endothelial cells. And this is the work that we have a patent, and I just wanted to give that financial disclosure. We know embryologically that we have optical vesicles, and then with evagination, we will have finally the lens and the cornea. And we know that the corneal endothelial cells are derived from neural crest cells. So now we wanted to go from pluripotential stem cells to eye-field stem cells to neural crest stem cell, and therefore to the corneal endothelial cells. Just to show you a few slides on this, And here it is, just a couple minutes. Induction of eye field stem cells from human pluripotential stem cells. And these, you can see the PAC6, LHX2 staining all the way through, that we have the eye field stem cells. And from eye field stem cells, actually, we can go to retinal cells. So all the way from stem cells, look at this, to RPE cells. And from IPS, again, we can go to neural crest cells. And look, our endothelial cells that are from neural crest cells have sodium potassium ATPase pump. You can see the NCAD herring staining, and ZO1 showing the junctions of the cells. And look at the nice hexagonal cells that we have at the end. So from human IPS cells, we have gone all the way to corneal endothelial cells. So can we do topical therapy and cell therapy? And here are our colleagues in Japan who have come up with the idea of ROCK inhibitors as an eye drop to accelerate corneal endothelium healing. And they even published it in New England Journal of Medicine. We have screened all of the ROCK inhibitors and have found a different one, H1152, to be a very potent healer of cell proliferation and cell migration. Look at this in these rabbits that I've injured, and you could see by day 10, it's a lot more clear if we are giving these topical ROCK inhibitors compared to rabbits that haven't had the treatment. So this is the normal endothelial cells in rabbit, the treated and the untreated ones. So finally, what are we working on? So we have the stem cells, and from the stem cells, we can correct the endothelial cells. The transcription factor repeats within the stem cells, which have maybe 50 copies or more of the CTG repeats within them. And then we can go all the way, convert to endothelial cells and potentially put it back in the patient. So that would mean that when we have a patient with Fuchs dystrophy, potentially I could get some of their skin cells or even blood cells. Currently from that, I could make their stem cells from those cells. And currently from that, I could make it all the way go to endothelial cells. The idea is that we are working on taking out at the stem cell level the disease part with the CRISPR-Cas technology. And the CRISPR-Cas technology is just like the Microsoft Word. If we fall asleep when we are typing and we put a letter A 50 times, we could cut it out. And the same idea is in the stem cells, to cut out the disease portion and then convert it to the endothelial cells. And that's what we are working on. So we've gone a long way in corneal transplantation, from PK to DSEC to DMEC to cell injection and stem cell therapy. It has been a long road, but a great road. And I think we are up to, in the next decade, a lot more advancements in the field of cornea. We have had keratoprosthesis that have gone long ways, but hopefully for those patients, we will also have a lot of treatments. So thank you at the end, and wanted to say how exciting to be here, how exciting to be in this junction for cornea in terms of transplantation, as well as a field as a whole. And these are my colleagues. Wanted to thank you for your kind invitation, and I'll stop sharing.
Thank you, Dr. Afshari. Very interesting. It's amazing how far corneal surgery has come. You've contributed so much yourself, and we appreciate that. And it'll be interesting to see what the future holds. I think it's so interesting how you showed that the transplanted endothelial cells can have so much damage done, but then so effectively keep the host cornea detergest post-operatively. So very interesting work that you've done. Thank you for spending.
Thank you so much. Thank you so much. There is a question from Dr. Vince DeLuise, which I'm grateful for his very kind invitation. We're saying, can I make a comment about DWEC, Decimase, stripping without endothelial keratoplasty? And that is getting quite a popularity as well. Hopefully, there are some compounds that are coming out, including folks are working on growth factors such as FGF, and there are companies that are working on that, that could make the Decimase stripping only more predictable, because there are certain percent of patients that don't clear once we do Decimase stripping only. But that is another amazing advancement within the field of cornea, that we can just take out Decimase stripping and not even put endothelium, and these patients do well.
Thank you so much, Natalie.
Thank you, Vince.
Great. Thank you so much for your time today. And this concludes our CME program for today.